genetics to advanced treatment and multidisciplinary strategies. This gathering reflects our shared commitment to advancing knowledge, improving patient outcomes, and strengthening collaboration in oncology. To officially open our program, may I now invite our Managing Director, Dr. Qasim Ardati, to deliver the welcome remarks.
Assalamu alaikum, masa al khair, good evening everybody. It is really a great pleasure to see so many friends and new friends that I have just met recently. I would like to specially thank Dr. Raja Al Yusuf for coming to us. She is the Vice Chairman of the government hospitals, and we are very privileged that she is here. We are privileged to have the excellent team of doctors from King Hamad, from other hospitals, and I'm really very happy that we are having the chance to discuss this topic, since it's a very important topic on the medical, genetics, surgical, prevention, oncology, and the experts here are here to share their expertise. Hopefully all of us will be learning, will be in a better position to learn more for the objective of diagnosing earlier, preventing, and hopefully treating as early as possible. So I'm looking forward to learn, and I'm looking forward to hear all of you participating as speakers or as panelists or as members of the group in this very enriching type of meeting. Thank you for coming.
Thank you, Dr. Qasim. Now, to take us through the agenda and set the stage for today's discussion, may I now welcome our consultant medical oncologist, Dr. Chaturbhuj Agrawal.
Good evening all, and warm welcome from BSH family. And so today we are going to discuss colorectal cancer, which is most important cancer which we see in Gulf region. Nowadays, we all must agree that we are looking more and more young patients with colon cancer. We are trying to convince patients to follow screening programs, which is still not 100% effective. So today we will be discussing colon cancer from diagnosis to treatment. So to introduce the agenda, first of all, we'll go with the gastroenterology perspective, because our doctors, they are the first pillar where patient goes and they diagnose and then they refer to us. Then we have genetics of colon cancer, which is very important as far as their treatment is concerned and further screening is concerned. Then after that, we will discuss the surgical aspect, then the adjuvant treatment, then the metastatic treatment, and after that, we will have a panel discussion on the rectal cancer, because I wanted to include the colon cancer and the rectal cancer as well. And in the end, we have two very experienced radiation oncologists giving the take-home message from the radiation oncologist and from the medical oncologist. And in between, we have the role of interventional radiology coming up. So Dr. Muntir is with us, and he will tell that how he's changing the landscape of treatment through a lot of new interventional methods coming up. So yeah, so the floor is open now, please. Thank you.
Thank you, Doctor, for outlining today's program. Our first session is one of the most important, as it addresses the foundation of colon cancer management, which is screening and early detection. Our speaker is one of the pioneers in gastroenterology, having trained in internal medicine at Wayne State University and completed her fellowship at Baylor College of Medicine in the US, where she was notably the first woman accepted to the program. Her career spans decades of clinical excellence, teaching, and research. She has authored numerous publications, contributed to international conferences, and remains an active leader in advancing gastrointestinal medicine. At Bahrain Specialist Hospital, she not only serves patients as a practicing consultant gastroenterologist, but also guides the institution as its vice chairman of the board of directors and chief of internal medicine and gastroenterology. It is a true honor to introduce our distinguished speaker for this session, Dr. Najah Rashid Zayani.
Thank you for attending this conference. It's with great pleasure that I see our physicians as well as physicians from the community, and I'm very happy to be among you and introduce the topic of colorectal cancer screening. The burden of colorectal cancer is enormous. 1.9 million cases per year are detected in the last statistics in 2022. It is also responsible for the highest number of deaths related to cancer, estimated about 935,000. All over the world, it's the third most common cancer, and this is a potentially different story if we screen and we get rid of the early cases before they develop into cancer. So 20 to 40% reduction has been witnessed with the introduction of colorectal screening in Western societies. How common is it? Colorectal cancer is the third most common cancer in Europe and the United States. According to the Bahrain Registry 2020, colorectal cancer is #1 malignancy in males and the second most common malignancy in females. The rate is expected to quadruple in the next 3 decades if we look at statistics and the way this cancer is rising in our society. Unfortunately, the peak onset in Bahrain is at a younger age by 1 decade versus that of the West. So the peak incidence is between 50 to 60 years. This should allow us to think about our screening strategy in a different way. Age standardized rate for males in Bahrain is 13.7, for females 14.6. In the States, it is 35.9 per 100,000 person per year. So we are still not as high as the West, but definitely we're catching up as the incidence increases. Colorectal cancer burden is subject to great change if we follow a screening program, and this being demonstrated in the United States, where the actual incidence of this disease decreased after introduction of colonoscopy screening in the 1990s. Obstacles in our society to screening were exemplified by this study, where a survey of 174 primary care physicians were done between 2021 to 2022. This revealed that 52% of our primary care physicians have poor knowledge of colorectal cancer screening guidelines. 60% screened less than 25% of eligible patients. 40% did not even bother to offer screening. 94% said that they favored a structured national program like structured vaccination programs, for example, to allow them to strictly adhere to the screening program. Top reported barriers were very short consultation time with patients of average 8 minutes. How can you introduce screening in 8 minutes? This is cited by 90% of the doctors. Poor patient awareness and poor compliance by refusal of a screening is another obstacle. There is lack of national guidelines and limited access to colonoscopy when the patient has symptoms. Colon cancer in Bahrain started the screening program in 2019 in a very limited fashion in the government of Muharraq area and Hid. They followed the fit test screening, which is a stool screening. But unfortunately, if we go back to statistics of colorectal screening in Bahrain, by a study exemplified by the Salmaniya, published by Al-Sheikh and Dr. Shubar, revealed that among 172 colon cancer cases reported between 2016 and 2019, younger age group is detected. About 25% of cases were detected between 45 and 54 years of age. Majority of cases, unfortunately, diagnosed at very advanced stage of disease. All patients were detected by symptoms rather than by screening, so we are failing to recognize early cases by screening. Among patients seen at the Bahrain Specialist Hospital, 25% had positive family history, which should be a big clue to early screening, and 25% of cases were below age 45. The incidence in Bahrain compared to the Gulf states, we are the third among the Gulf states in incidence. We follow Qatar as number 1, Saudi Arabia number 2, and we are the third. There is much lower incidence in Oman and United Arab Emirates. I'm not sure though of the data, whether it is correctly collected and whether these cases are missed because of poor referral. Colorectal screening. Why do we need to screen? Fortunately enough, colorectal cancer does not start as a cancer. It starts as a polyp in 90% of the cases. This allows us a beautiful window of screening between 7 to 10 years from development of a polyp to development of cancer. In this golden period, if we detect this at a stage of polyp, this is stage 0 of disease. Removing the polyp can prevent the development of colon cancer. Identifying precancerous polyps and removing them can prevent 90% of colon cancer. Colon cancer is curable if detected early, and surgery offers a long-term cure. Therefore, we need to really work on screening for early lesions like polyps, removing them, and if we detect a colon cancer at an early stage by screening, this really improves the mortality of our cases. It is the only cancer in the world where screening has been proven to reduce incidence and mortality. As I said, it starts as a tiny polyp, very easy to remove by colonoscopy, progresses to a bigger polyp, which is harder to remove, and eventually into cancer. This is a case I detected last month, a young woman with family history of colon cancer. She came in with history of minor rectal bleeding, no other symptoms. She has this huge polyp, removed easily, and the histology showed that there is very high dysplasia in this polyp. Therefore, it was going to go evolving into cancer very soon, if not removed. Unfortunately, we see cases mostly in this stage of tight stenosis or fungating circumferential colon lesion. These usually will require surgery, and the mortality rate and the prognosis is not so good. What methods do we have of detecting colon cancer? Of course, the cost as well as availability of resources plays a major role in what screening method we're going to follow. For example, colonoscopy, which is recommended every 10 years, starting at age 45, has an average cost of between 300 to 400 BD. Fecal immunochemical test, which is followed in Bahrain now and available in all health centers, is a cheap test between 3 to 4 BD. However, it has to be done annually from age 45 to 75. Multi-targeted stool DNA test, which is now available commercially, is 10 times more costly, and it has to be done every 3 years. And the latest player in this screening strategy is a blood test, which is the easiest to do because you don't have to rely on the patient bringing the stool test. You don't have to convince them to bring a stool sample, and many patients, believe it or not, refuse to collect a stool sample. The blood test is a single blood test done in the office every 3 years. It is still very costly, and unfortunately there is no good validation on the sensitivity and specificity of this test. I will share with you, however, the data done on 27,000 patients. Therefore, screening strategy depends on patient choice, If the patient refuses to come for a colonoscopy, you have no choice but to do either a stool or a blood test to detect the accuracy of the test, depending on which method you're going to follow and how adherent they're going to be to your follow-up plan as soon as you find a positive test. Colonoscopy is the gold standard. It is both diagnostic and therapeutic. It detects the lesions with a high sensitivity of 93%, and an adenoma is detected, which is a precancerous lesion, in about 75 to 93% of cases. Interval is every 10 years if the colonoscopy is normal, and the cost is higher, but it is a one-time stop for 10 years. So once you do it and you have a negative colonoscopy, you can then think of the next step after 10 years. It requires well-trained manpower. It requires preparation, sedation, recovery space, and therefore not every community can afford it. The risk is very low. It's about 0.1 for perforation or for bleeding. It is limited by patient acceptance in our society. Most people will refuse to cooperate, and I'll show you why. The quality of the preparation is a big limiting step, because if you do a colonoscopy on a dirty colon, you will miss these adenomas. You might even miss a cancer. The skills of the endoscopist, the equipment, and availability of time with the patient to really take care of the preparation is essential for doing a good colonoscopy. When is it the first choice? You should never really send a patient with symptoms to stool testing. It's useless, because you may miss that occult positive stool. If a patient presents with things like rectal bleeding, abdominal pain, persistent change in bowel habits, or iron deficiency anemia, please do not wait for a stool fit test or any other non-invasive test. Go directly to colonoscopy. If there is a personal history of colorectal cancer previously diagnosed, inflammatory bowel disease, which is very common in our society, first-degree relative with colorectal cancer or advanced adenoma, skip the stool test and non-invasive test and go to a colonoscopy. Family history. If we recognize that 25% of our patients have positive family history in Bahrain and in the Gulf region, then start screening 10 years younger than the youngest member affected in that kinder. And also, try to screen as early as 40 years of age if you don't know the exact age of the affected person. But if they have a young person in the family, you have to start earlier than routine screening. If two first-degree relatives have advanced adenoma at any age, start early screening, go directly to colonoscopy. Don't wait for stool test. Now, one of the qualities of a good colonoscopy is how often does this colonoscopist detect adenoma? Not everybody is equal. Some people do a colonoscopy, they quickly put the scope in and out, and they miss the lesions. There has been great discrepancy between various colonoscopy units on the adenoma detection rate, which is now considered a benchmark for quality of a colonoscopy. First, you have to clean the colon very thoroughly. If the colon is covered with stool, you will miss these polyps. You will miss sessile serrated lesions, which are precursors for cancer. According to the Multi-Society US Task Force for Colorectal Screening, the benchmark should be 30% among males should have adenoma detected, and 20% among females. On average, we'd say 25% is the minimum detection rate to call a colonoscopy unit efficient. Over 10 years, the rate of transformation of this polyp to cancer is about 6 to 10%. So if you have a polyp today and you don't remove it, you have a chance of about 6 to 10% of that going into cancer. Since each population is unique, we don't really know what's happening in our society. How often do we meet this adenoma in our patients? So I carried on data collection at our unit between the year 2000 to 2025. And to my surprise, the adenoma detection rate was quite high. It was 31% for males and 23% for females. Therefore, we expect that if 10% of these people go into cancer, we have the potential of curing them, finding these adenoma at a young age. What are the other options if the patient refuses a colonoscopy or a colonoscopy is not available in your area? I'll compare for you the non-invasive modalities versus a colonoscopy. Colonoscopy has a very high sensitivity of 95 to 99% if done properly, and a specificity of 99%. FIT test, which is done in Bahrain, has a sensitivity of between 74 to 80 and a specificity of 94 to 96. In other words, a lot of FIT positive patients are going to end up with other diagnoses causing blood in their stools. For example, hemorrhoids, colitis, or any other lesion causing bleeding. Fecal occult blood test is no longer used as a screening test because of low sensitivity, so forget about that as a modality of screening. Stool DNA is becoming a very important modality for screening, and it's improving by the day. So what we look for is DNA markers in the stool. And it is a very high sensitivity test of 92 to 94% with specificity of 87 to 90%. It is costly, and it is being validated more and more by further studies. The latest, and I think the most promising for the future, is a blood-based detection of DNA as well as proteins secreted by colon cancer in the circulation. So with a single blood test, you can tell your patient, yes, you have a chance of having colon cancer, go quickly for colonoscopy. It has a sensitivity so far validated about 65 to 70%, and it is highly specific if positive at a rate of 85 to 90%. It is expensive. It's about a cost of $300. Fecal occult blood test, FIT test, which is commonly used in Bahrain, now available in every health center and free to the patient, is non-invasive. It detects only occult blood, so it doesn't detect colon cancer. It just detects any bleeding inside the GI tract. It has a low sensitivity, really, between 71 to 91, and a specificity of 90 to 96%. Unfortunately, it has very low adenoma detection rate. So you're not going to catch the early adenoma by a FIT test. You will catch the advanced adenoma or the bleeding adenoma. Only sensitivity for adenoma is about 20 to 25%. It requires annual testing at between age 45 and 75, and if positive, the patient has to be directed to a colonoscopy. The cost is cheap at 3 to 4 dinars. However, you need a lot of staff to follow results, call the patients, convince them to come for colonoscopy, and I'll share with you the experience in Bahrain here of what happens when a patient is screened with FIT and is found to be positive. Compliance so far in Bahrain is about 25% among the population, and patient failing to return a stool sample or failing to come for a colonoscopy when the FIT test is positive is a big obstacle. We come to multi-target stool DNA test. This is becoming popular now because you can detect the tumor markers in the stool. It has a better sensitivity for colorectal cancer of 92% versus FIT at 74%. It has a better sensitivity for detecting adenoma, but is still not perfect like a colonoscopy. So sensitivity for detecting adenoma is 42% only. You will miss more than half the adenomas by doing this test. It is specific for colon cancer at a rate of 86 to 90% versus FIT at 95%. The cost is 20 times higher than a FIT test. It is not available in Bahrain, and they are developing better and more sensitive DNA tests in the stool. Coming to the last modality, and this was validated in a study called the PREEMPT study, where the single blood draw is done before a colonoscopy, and they correlated it with the gold standard of a colonoscopy screening. And in this test, published in American Journal of Gastroenterology, a single blood test was done on 27,000 patients who underwent colonoscopy screening, and they correlated the sensitivity of detecting colon cancer by the blood test positive by colonoscopy, and it had a sensitivity of 79% and a specificity of 91%. Luckily enough, it even detected early stage cancer at stage 1 in 57% of the cases. However, it has poor adenoma detection rate. So again, we miss the chance of detecting the precancerous lesions. It is expensive. It's about $300 per test. So how do we impact the incidence and the mortality of colon cancer? How much do these tests actually change the outcome of patients and societies? Still, the gold standard is a colonoscopy. We can decrease the incidence of colorectal cancer by 79% and decrease the colorectal mortality by 81%. Nothing so far matches this as far as non-invasive tests, as you can see. So what test do I offer my patient when the patient comes to clinic? You have to risk stratify if the patient has a positive family history or has symptoms or has shown findings of change in bowel habits. Don't wait for a FIT test. Go directly to a colonoscopy. Understand that if a patient is refusing a colonoscopy, you still can offer them a non-invasive test. Hopefully it will be positive to convince them. Discuss potential outcome and discuss that a positive FIT test will mean a colonoscopy. If they refuse to follow that, then you are missing your chance of doing some service to that patient. There is superior compliance with choice, and this study actually demonstrates that. You cannot force a patient colonoscopy or none. If they refuse a colonoscopy, do offer them at least a stool test, FIT test, and hopefully it will pick up their lesion. Non-endoscopic screening tests on incidence and mortality is not that great. For FIT test, decrease incidence by 10% only, decrease mortality 22 to 62%. Similarly, for the stool DNA and for a blood test, and blood test is not validated yet how much it affects mortality and incidence. Colonoscopy, which is the gold standard, is still not perfect. The reason is patients refuse colonoscopy or they come unprepared for a good colonoscopy. So the impact on incidence is between 40 to 69%, not 100%, and the mortality is affected 29 to 88%. Still, it is the gold standard because it offers screening for high-risk patients. It's a one-time test. You can do it every 10 years. You identify and remove precancerous lesion, and it has long duration of protection. So if you get a negative colonoscopy, you can easily wait 10 years to have your next colonoscopy done. Non-endoscopic tests have a role to play. They do decrease colon cancer mortality and incidence, not as much as colonoscopy, and they offer probably improvement in compliance to listening to the doctor for undergoing a colonoscopy screening. They are good choice for average risk patients, not for high risk patients, and therefore meet your patient where you can convince them at least to undergo some screening. If I compare a statistical model of what is the best strategy for Bahrain, assuming that 50% of patients will accept a colonoscopy at counseling, assuming that the doctor has the time to counsel a patient, the acceptance rate for colonoscopy is about 50%. Colonoscopy in the first round, you need to screen 300,000 patients in Bahrain today to do an adequate screening, assuming that 50% of them will accept a colonoscopy, and you will detect cancer in 2 to 4 per 1,000, or advanced adenoma in 25 per 1,000. The annual eligible cases will be 15 to 20, reaching the age of 45,000 per year, and initial cost is estimated about 35 million BD. Annual budget has to be set at about 6 million BD at least to continue this strategy. It requires staff, well-trained staff. It requires preparation, sedation, recovery unit, and you have to remember small yet important complication rate. If we follow the FIT strategy of screening, the acceptance rate all over the world is about 60%. In Bahrain so far, it's not that common that the patient will actually bring the stool sample. They may agree to do the test and then fail to bring the stool sample, so you lost that patient. It requires no preparation. It has a sensitivity about 75 to 80%, and about 6% of the population screened all over the world will be positive on FIT test, and they will require a colonoscopy to follow. If we assume strategy of 6% as screening 300,000 people, at a 60% acceptance rate, it will come to about 12,600 colonoscopies in the first go, and it will cost approximately 47 million dinar. It requires dedicated staff who will follow results, who will call the patient, who will convince the patient to come to colonoscopy. So I want to share our local experience so far, and this is kindly given to me by Dr. Omar Sharif, who is following up the FIT test program in Bahrain. In the first round, which started in 2019 to 2025, 20,000 cases were screened in Bahrain, and there was 1,398 positive cases. 580 were males, and the rest were females were 580 and males 798. Colonoscopy was recommended to these patients, but only 859 attended. So we lost quite a number of patients who refused a colonoscopy in spite of a positive FIT test. They refused to attend. The findings on these colonoscopies, they diagnosed 67 colorectal cancers and 177 large advanced polyps and 259 small polyps. Other lesions like colitis and hemorrhoids were responsible for the rest of the cases. Global lessons. We learn lessons from other societies who started screening in the 1990s, and in the US and Korea and United Kingdom, a FIT test screening strategy was started in 1990s, and the compliance rate, as you can see, is not perfect, between 65 to 70%, but there has been a dramatic decrease in mortality of colorectal cancer of about 42% to 36%. That's still good enough to start this program in Bahrain and follow stringent guidelines to screen people and follow them up after a positive test. In conclusion, there is no test that is perfect, but colonoscopy is the best option we have so far for detecting precancerous and cancerous lesion. Due to the cost and lack of resources, presently we cannot assume that we can do this thing in Bahrain. We have to follow other modalities of screening, and hopefully in the future we will aim to do universal colonoscopy screening. We need to make the people aware that this is a cancer that is preventable by polypectomy. The incidence at young age in our population needs special attention, so maybe we need to move the screening time to age 40, like they did in the United Arab Emirates. The risk stratification of patients is very important to offer screening. Manpower training should start now to train more endoscopists and more technicians who can help them, and more space for endoscopy. So we can shift from the FIT test, which has a sensitivity of 75%, to a colonoscopy, which has sensitivity of 95%. Development of stool tests and multi-targeted stool tests and blood-based tests in the future may help us reduce the need for colonoscopy, but so far they are not perfect. Again, we have to educate the public to the prevention of colorectal cancer by reducing risk factors like obesity, sedentary lifestyle, smoking, and awareness of family history. If the patient is aware of family history, that's very important. This is our team. I want to thank every member of our team who really cooperates in screening these people, and calling them back about their results, and convincing them to go for the screening tests. Thank you very much.
Thank you, Dr. Najah, for that very insightful presentation. Our next session explores the genetic foundations of colon cancer, a field that continues to transform how we approach screening, diagnosis, and treatment. The speaker is a highly accomplished physician who earned her PhD in molecular and clinical medicine from the University of Edinburgh and went on to establish the first genetic screening clinic and first pre-implantation genetic testing or PGT center in Bahrain. She has held key leadership roles, including Director of the Bahrain Oncology Center Laboratories at King Hamad University Hospital and consultant in medical genetics. Recently, she also established the Medical Genetic Department at Al-Kindi Hospital. Beyond her clinical and academic contributions, she is actively engaged in spreading awareness regarding conditions related to her field, including cancer, premarital genetic screening, infertility, and recurrent miscarriages, and also PGT. It is my honor to introduce our distinguished speaker for this session, Dr. Mariam Fida.
Assalamu alaikum. Good evening. Let me start by thanking Dr. Akrawal, Mr. Yatish, and Ms. Leslie, and everyone else for their kind invitation to be a speaker in this very important symposium. So my name is Mariam Fida. I specialize in both medical genetics and PGT, pre-implantation genetic testing, which in simple terms is detecting genetic abnormalities in embryos and then transferring the healthy unaffected ones into the mother. And by doing so, you're eliminating genetic conditions in future generations, sickle cell disease, beta thalassemia, even inherited cancers. We also use PGT for couples with infertility and recurrent miscarriages, but we use a different type of PGT because, as you all know, as we grow older, our chromosomes get sticky. They do not divide properly to form the eggs and the sperms, so the risk of having an aneuploidy or an embryo with a syndrome increases. And I'll come to that at the end of my talk, inshallah. Whenever I'm asked to give a talk, I always like to start with the basics of genetics, just to refresh your memories. So for those of you who have attended my talks before, please bear with me for the first 2 minutes. And then I usually go over cases. Since we're talking about colon cancer today, I'll just show you cases from my clinic with different cancer mutations or related to colon cancer. And like I said earlier, I'll conclude, inshallah, with PGT. So let's start with the basics. You all know that our bodies are composed of cells. Inside our cells, we have the nucleus. Inside the nucleus, we should normally have 46 chromosomes. Obviously, half of them from mom and the other half from dad. Males would normally have 46 XY, and the reason why I would say normally is because I've seen a case where a male was 46 XX because of a very rare condition where he had a gene translocation. So he was 100% male sitting in front of me, but because of a gene translocation, he could not have children, and that's why he came to my clinic. And this is one of the DSDs, disorders of sex development. In Arabic, we call it اضطراب التطور الجنسي أو اضطراب النمو الجنسي. It's when your chromosomes do not match your sex, or when your chromosomes do not match your genitalia. Females, on the other hand, would normally have 46XX, and again, the reason why I would say normally is because I've seen a case where a female was 46XY because of a genetic condition she inherited from both her parents. Just like the Algerian boxer Iman, do you remember her? Okay, so Mulakima al-Jazairiyya Iman, you probably remember her from last year, from the Paris Olympics. As per her latest reports, she's actually a biological male. She's 46XY, but because she has an autosomal recessive rare genetic condition called 5-ARD, and that's why she was born with what we call ambiguous genitalia. So 5-alpha, I'll just go over it briefly. 5-alpha reductase deficiency is very important in male embryos because what it does is it converts testosterone to dihydrotestosterone. Dihydrotestosterone, or DHT, is a very important enzyme in the development of the male external genitalia and the prostate. So for those who have a deficiency in this enzyme, testosterone is not going to be converted to DHT, and therefore the baby could be born with ambiguous genitalia. Like I said, they could have genitalia which resembles a female genitalia. They could have undescended testes. They would have hypospadias and micropenis. So this is what happened with this Algerian boxer, and this is why she was raised and treated as a female. Because later on, her body started making testosterone. This is why you could see her during puberty. She went through normal male puberty, and that's why you can see her physique, the way she talks, the way she walks. It's a typical male. If you open up all those chromosomes, you're going to find genes on them. And as per the latest studies, we have around 20,000 genes. If you open up the first chromosome from the upper tip and hold the last chromosome from the lower tip and just open up the whole DNA, you're going to find that the whole DNA is composed of around 3.2 billion letters, or what we call the nucleotides. This is one of the smallest genes that we have, the HBB gene. So if there is a mutation in the HBB gene, the baby could be born with either sickle cell disease or beta thalassemia. So those two conditions occur because of different mutations in the same gene. And I'm sure you all know the process. So we have the DNA through the process of transcription. We have the mRNA through the process of translation. We have the protein. So every gene gives us a protein. In this case, the gene is HBB, and the protein is hemoglobin, our regular hemoglobin, which we check every now and then. So let's move on to the variants. Please keep in mind that we don't use the word mutation anymore. I know in Arabic we still call it tafra because we don't have any other word to use, but in English, the word nowadays is a variant. And we also go by the classification of the American College of Medical Genetics and Genomics. The variants are divided into three. We have a pathogenic variant, which is a variant that contributes to a disease, no matter what the disease is, whether it's cancer, sickle cell, any other type of disease, genetic disease. We have benign variants. Benign variants are variants that do not cause a disease. So our hair, our skin tone, this is not a disease among us, we're just different. And then we have something in between, which the American College has put it in between those two. We call it the VUS, the variants of unknown significance, or the variants of uncertain significance. And these are the ones that, as per the American College, they don't know whether to put it as a pathogenic variant or as a benign variant. So they kept it in between. And this, unfortunately, is most of the variants that I see in Bahrain of our cancer patients or even pediatric patients. And this is why I don't always go by the classification of the American College. I always take a detailed history, personal history, draw the pedigree, check the gene, the function of the gene, and then I decide whether this is a VUS in our part of the world or a pathogenic variant, and not going by the classification of the American College. And I'll show you one of the cases that we had. So let's move on with the first case of an MSH2 gene. If you can look at this gentleman, if you can see throughout the years, he has gone through lots and lots of different types of cancers. This case was referred to me by Dr. Mohammed Rafi', the head of the radiology department at KHUH. So when he referred him to me, I had to take a detailed history, and this is how the pedigree looks like. So this is the gentleman there. This is the gentleman. His father passed away of colon cancer, and his brother also passed away of colon cancer. When I started asking about his children, he told me that his daughter passed away a few months back. And when I asked him who his daughter is, she turned out to be my patient, actually. And I still remember her because she came to my clinic breathless. She had metastasis at that time, and we had to refer her to the emergency. Unfortunately, she passed away a few weeks later. Now, one thing that I wanted to say here is I got the daughter genetically tested, and whenever I get people genetically tested, I always tell them, when they have a mutation, please always tell your siblings, your brothers, your sisters, and your children to get tested. Unfortunately, in our part of the world, rarely do they tell their siblings or their family members that they have a mutation or that they even were diagnosed with cancer. So when I asked her father if actually she told them, he said that he was not even aware that she had a mutation. So obviously I knew what his mutation is because his daughter had the same, probably inherited the same mutation from him. So he turned out to have a variant in the MSH2 gene, a pathogenic variant, which increases the risk of developing Lynch syndrome. So there are 5 genes associated with Lynch. MSH2 is one of them. So whenever I get the report, I analyze the variant. So this is how this part of the gene looks like. So we're supposed to have G in that intronic part. He had an A, so this is what we call a substitution mutation. And this is the mutation that increases the risk of developing Lynch syndrome. And at the end of the report, I would have a small interpretation just to explain what this mutation is, what it means, and which disease is it associated with. Please keep in mind that pathogenic variants are inherited by 50% because we have 2 copies of every gene, one from mom, one from dad. Cancers operate as an autosomal dominant condition, so they would either get the mutation or the pathogenic variant, or they would get the normal variants. That's always, normal gene, excuse me, so it's always 50%. Moving on to the next case. So this is a girl in her 20s. She's married to a relative. She has, as you can see, young children. She came to us because of abdominal pain and nausea. she turned out to have colon cancer with metastasis. She told me she does not have any family member diagnosed with cancer, even though her father is married to more than one wife, and she has lots of brothers and sisters, aunts and uncles, but she insisted that no one in her family was diagnosed with any type of cancer. So when I got her genetically tested, look at this. This is one of 3 rare cases that I've seen in my career. She actually had 2 pathogenic variants, one in the APC gene, which is associated with colorectal cancer, and one in the BRCA1 or BRCA1 gene, which, as you all know, is associated with breast and ovarian cancer syndrome. Her medical oncologist, I remember it was Prof. Hussein Abali at KHUH at that time. So he requested the DPYD gene screening. Why? Because those patients who have a positive result would actually refrain from using 5-fluorouracil. So this is how the DPD part of the DPYD gene looks like. It's quite a humongous gene, so I'm just showing you a few exons. What happens here is this is where the mutation is. So because of the mutation, we would have splicing out of exon 14, and therefore you will not have exon 14, and the final mRNA would miss exon 14, and this would increase the risk of having the variant. So this is how the variant looks like. Instead of having a G, they would have an A, and this girl turned out to be negative for this variant, so they proceeded with 5-fluorouracil. The other thing that I wanted to mention, she went through lots of things, and she underwent a colostomy because of her obstruction, but also her physician at that time, her oncologist, requested the MMR. So let me go over the MMR briefly, because this is a test that is requested by my colleagues in medical oncology and surgical oncology a lot. So let's say this is the cell, and this is the repeated sequence. I mean, unfortunately, this is not working on the screen, but usually in the DNA, we have what we call repetitive sequences, and repetitive sequences would increase the risk of DNA replication error. So in this case, I'm just showing you, for example, the repeats are CA, 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 CA. So if there was a replication error, let's say instead of AC here, we have CA. There are 2 things that could happen. If your MMR is intact, the MMR system is intact, the cell is going to fix itself, the DNA is going to fix itself and bring it back to CA, or AC, excuse me. And this is when we say that the MMR is proficient. We use the word P instead of before the MMR. So we say that this tumor is microsatellite stable. If the MMR is deficient, and therefore the system cannot fix now the DNA, it will stay as CA, and therefore we would say that this is MMR deficient, and we use the letter D before MMR, and we would say that this is microsatellite instability high. And my colleagues in medical oncology are going to explain later why is this important for immunotherapy. Moving on to the 3rd case. So this is a gentleman, a 30-year-old gentleman who came to us because of rectal bleeding and weight loss, and he was also diagnosed with colon cancer metastasis. When I asked him who in his family was diagnosed with cancer, he was also not aware, so he only mentioned a couple of patients. I'm sorry, let's go back. So a couple of his relatives. And when I got him tested, he turned out to be positive for a pathogenic variant in the BRCA1 gene. Now, whenever a report comes back, I always analyze the variant, like I said earlier, so I would have at least 2 pages of the report. Unless the protein is very huge, then obviously it will take longer. But here what happens is this is how the normal sequence of the gene in this area should look like. We should be having TCAE in this region, and I see this mutation a lot, by the way, in Bahrain. This gentleman had a deletion of those 4 nucleotides. So even though it's not really a big deal, because some people tell me, okay, we have 3.2 billion nucleotides, why would you care if we lost 4? We lost 4 because what happens here is we have what we call a frame shift mutation. So the DNA is going to be reading it improperly, and we would have an earlier stop, and therefore the final protein would be truncated. So this is, the upper part is the normal protein of BRCA1, which we should all have. Because of the mutation, there are new amino acids which developed, and there was an earlier stop. This is why we say this is a truncated protein now. And this would increase the risk of developing different types of cancers. So for this patient also, the medical oncologist requested the MMR system, and the MMR was done on a protein this time, not on the DNA. And you do that by immunohistochemistry, IHC, and you use the proteins from 4 different genes related to Lynch syndrome, and he turned out to be MMR proficient, so there was no instability in his microsatellites. Now, the reason why I'm mentioning this is because he does not have, he does not have Lynch syndrome, so obviously his MMR is going to be proficient. And this is, again, a small interpretation of what this gene is associated with. Please keep in mind that BRCA1 and BRCA2 in females are associated with breast, ovarian, uterine, pancreatic, and colon. In males, because many patients come to me and they say, okay, we're not going to test our male children, we're only going to do the test for our female children, and this is not correct because the gene does not know that it's actually in a male or in a female. So males, this gene would increase the risk of developing breast cancer at 1%. It would increase the risk of prostate cancer. My colleagues in medical oncology would tell you that. It would also increase the risk of colon cancer and pancreatic cancer. Again, because this gene acts in autosomal dominant condition, so we always tell their relatives to get genetically tested because there is a 50% chance of passing it on. If those people would like to have children not carrying this mutation, we also advise them to go for PGT, pre-implantation genetic testing. Let's move on to the last case of APC. This is, by the way, a variant of unknown significance. So this is a 63-year-old female, came with rectal bleeding, weight loss, and she was diagnosed with colon cancer. So this is her, and as you can see, her brother was also diagnosed with lung cancer. Her both sisters were diagnosed with colon cancer, and her mother was also diagnosed with lung cancer. When I got her genetically tested, she turned out to have a VUS, a variant of unknown significance in the APC gene. And again, this is how the report would look like. When I analyzed it, instead of having a G in that area like we do have, she actually has a substitution mutation. She has an A. And this would increase the risk of having colorectal cancer. Please keep in mind, like I said earlier, I do not always go by the classification of the American College of Medical Genetics and Genomics, because as you can see, even though they consider this variant a VUS, she actually has a strong family history, and the gene is actually associated with cancer, and she actually developed cancer. So please keep in mind that whatever is considered as a VUS in the US is not necessarily a VUS in our part of the world, because our genetic pool here is different. So let's briefly talk about PGT, pre-implantation genetic testing. It's like I said earlier, when you detect genetic abnormalities in embryos and then transfer the healthy unaffected ones into the mother. So one more thing. So I still hear my colleagues calling the specialty PGD, pre-implantation genetic diagnosis. Please keep in mind that since 2017, all those colleagues came together and all those entities came together and decided to amend the name of the specialty from PGD to PGT. And PGT now is divided into 3 categories. If you're checking the mutation, a gene mutation, like for example, sickle cell disease, the PGT is going to be designated as PGTM. If we're looking at chromosomal aneuploidies, an increased copy of a chromosome, a decreased copy of a chromosome, we call it PGTA aneuploidy. And then the lesser type of PGT that we do is PGTSR, structural rearrangement, which is a different term for translocations. So how do we do PGT? We give the mother ovarian stimulation medications for 10 to 14 days, regular IVF cycle, and then we retrieve the eggs, we fertilize them by the husband's sperm, and then we wait to day 3 for the embryo biopsy. If we're doing a fresh transfer, nowadays we don't go for day 3, we go for day 5 because the outcome is better. And then we take 4, 5, 7 cells, we analyze them, and then the healthy, unaffected ones we transfer back into the mother so that hopefully she would have a healthy, unaffected child. Thank you.
Thank you, Dr. Mariam, for that valuable presentation. Now, we finished with the first part of our session. So if anyone who have a question for Dr. Najah and Dr. Mariam, please feel free to do so. Yes, ma'am.
Thank you so much for the excellent presentations. My question will be for Dr. Mariam. How about Pol E, Pol D mutations? POL-E and POL-D mutations, because nowadays we are checking MSI, and if we are finding proficient MMR, the guidelines are advising to do POL-E and POL-D mutations, which are the most, not common mutations, very rare mutations, but if you will find, you have a target to treat the patient.
Thank you, Doctora. I haven't seen much patients with this mutation, to be honest with you. But again, if we're looking into them, I have to decide whether it's a pathogenic variant, whether it's a VUS, depending on the patient, whether they're affected or not, whether they're siblings or they have a strong family history. And then based on that, I could decide that whether to go for a pathogenic or whether it's a VUS. And based on that, I just contact my surgical oncologist or the medical oncologist. And based on that, I can tell them whether they can go further with their management and treatment plan.
Hi, thank you so much for the lecture, Dr. Najah and Dr. Mariam. So my question is, Dr. Najah, you mentioned that there's a lot of barriers to screening. What do you think, in your opinion, are with some of these strategies that we could do to increase the uptake and to encourage patients in the primary healthcare to screen? As like in the UK, what they did is that, if a GP reaches a target, then he would sort of get rewarded, and that's a strategy that they have done to encourage GPs to, help patients or advise patients regarding screening.
Thank you very much for your question. I think there are many ways to improve compliance to FIT screening, which is the policy in Bahrain. First of all, give more time to the physician to discuss. Have posters in the waiting area. Waiting areas are captured audience. You can have a big video presentation and people will watch it while they're sitting waiting for the doctor, or sitting waiting for a blood collection. They can see a big screen saying, this is colon cancer. Do you have a family history? Do you have rectal bleeding? Make it very simple to understand. Second, we're really not using our media in Bahrain to discuss these cases. TV, people watch TV more than they read newspapers. Put it on TV, bring awareness to the public. Shopping center is a captive audience, okay? One station in city center to educate patients, you will get exposure to thousands, okay? Second is you have to make people aware of their family history. So whenever I meet a patient with colon cancer, I always tell them, can I meet your sisters and brothers? Can I convince them? Can we go over your family history again in a group session? And this way we had picked up so many cases by just discussing family history. So again, make the patients aware of symptoms in a waiting area, in airports, in shopping center. Bring it up. Don't hush it. Our society hushes up problems under the rug. This is wrong.
Thank you, Dr. Najah, Dr. Mariam. Brilliant lectures. My question is to Dr. Najah. How often you meet a normal colonoscopy and a positive FIT test, and how do you go with that?
Okay, it's very common to see falsely positive FIT test. As you can see, even our data here in Bahrain has shown that among the 20,000 patients screened, 1,300 plus were positive, but not all of them had colon cancer or polyps. We found other reasons like hemorrhoids, colitis, inflammatory bowel disease, peptic ulcer disease, things which cause any positive blood test. You're going to find it. Now, no test is perfect. Even colonoscopy, you can miss lesions if you don't do it well. So I would tell my patient, you have a positive test, but you have other reason for having it. It's not a cancer, it's not a polyp. Go treat the colitis or treat the hemorrhoids or whatever it takes.
Thank you again for these two lectures. My question is for both Mariam and Dr. Najah. For the APC of undetermined significant, variant of undetermined significant, if we have different pool here other than the USA, so how to go about the guidelines? Is there a guidelines here, or how to counsel the patient actually in terms of intensive procedures or even total colectomy? So
the question is not the voice.
Okay. About the APC of the variant of undetermined significant, according to Dr. Mariam, that we have different genetic pools here other than the USA. Is there a guidelines for this variant in terms of treatment and management, in terms of colectomy, total colectomy, or diagnostic?
See, there are guidelines for pathogenic variants when it comes to the American College of Medical Genetics and Genomics. They do not go for any guideline regarding the VUS. So to them, the VUS, it does not exist. Like to them, it's a normal variant and you just move on. And this is why when I tell you here in this part of the world, I don't go by their classification, because if there are so many family members having the same exact VUS, this can't be a VUS. I remember having a patient who was diagnosed with breast cancer, and when I got her genetically tested, she turned out to have a VUS. A few months later, her daughter was diagnosed with breast cancer, having the same exact variant. So this cannot be a VUS. It's actually a pathogenic variant here, because you have a strong family history, you have the disease actually, and the gene is associated with cell division. So it is a pathogenic variant here. It's a bit complicated because I see the same thing with pediatric patients. Like I had a couple who had a daughter who passed away, and before she passed away, they got her genetic tested at SMC, and then because she had a VUS, homozygous, they told her that she can get pregnant again and have a healthy, unaffected child. She had another daughter with the same exact cardiomyopathy as the first daughter, and she also passed away. And when I got them genetically tested later on, they both had a VUS, the parents, the same VUS that both the daughters passed away from. And this is why we decided to go for PGT for them.
Thank you, doctors, for that very interesting discussion. Now, moving on to our next session, which will highlight how colon cancer presents and behaves differently in the Gulf region compared to other parts of the world. Our speaker, currently serving as a gastroenterologist at Bahrain Specialist Hospital. He holds an FCPS in gastroenterology, is a member of the American College of Gastroenterology and the European Society of Gastrointestinal Endoscopy, and has authored multiple research publications. It is my honor to welcome our distinguished speaker, Dr. Muhammad Manzoor Al-Haq.
Thank you. Good evening, ladies and gentlemen, and the distinguished speakers. So I'll be talking upon the pattern of the disease, particularly to the Gulf countries, and my talk is based on the published data from the GCC countries and how it is differed from the global trend. So the colorectal cancer incidence is rising all over the world, and the similar trend is observed in the GCC also. But the unique pattern in the GCC, that is the earlier age at the diagnosis, and the incidences are increasing because of the lifestyle and the obesity, diet, and the diabetes. So as we know that this is the third most common cancer in the world, around 1.9 million people are affected. New cases are diagnosed each year and 900,000 deaths each year are reported from this disease. So globally also there is an early onset colorectal cancer is increasing, likewise in the GCC. So this is the data where you can see that there is where we are comparing the Delhi, which is the disability adjusted life year. So you can see there the colon cancer has a higher disability compared to the rest of the cancers in the Bahrain, and a similar trend is followed in the rest of the GCC countries like Kuwait, Oman, and the United Arab Emirates. So there are multiple regional analyses and peer-reviewed studies that show that the CRC incidence has increased substantially in the GCC countries and is projected to continue increase due to the population growth, aging, and westernizing lifestyle. So this is the data which is taken from, which is published from the Saudi Arabia. You can see that there is an increase at incidence of the disease over a period of time over last 2 decades, both in the male and female genders. And again, this is also showing the incidence with the male and female gender in the various GCC countries, and the higher incidence in the Qatar, Saudi Arabia, Bahrain, and UAE. So this is the data which is taken from the Saudi National Registry, and you can see that the peak of incidence of this disease is rising in this particular younger age group, which is 50 to 54 years, and it is also a peak at the latter stage of the life. But this is the trend which is followed in the globally and also in the GCC area, which is more pronounced in the GCC area. So when the disease is diagnosed at an early age, so there are certain different pattern of the disease. For instance, they faces a diagnostic delay because most of the screening program is after the 45 years. So they don't undergo the stringent screening, so often diagnosed at a later stage of the disease. Not only the incidence which is increasing, but also there is a rightward shift is seen all over the world. Initially, the left-sided colon cancer were more common, but now the right-sided colon cancer is reportedly coming more and more globally, but still globally the left-sided cancer is common. But there are certain studies in the Saudi Arabia which showed that the right-sided colon cancer were 57% versus 42% to the left side, and another study which is showing that 61% were right-sided tumor compared to the left side, which was 32%. So these rapidly increasing incidences are associated with certain modifiable risk factor. So in this particular study, these risk factors which are modifiable are assessed in the GCC countries, and the topmost risk factors are the high body mass index and low physical activity and smoking, and the diet which is low in the fiber and the calcium content. The similar trend is followed in rest of the GCC countries as a risk factor, and these are the modifiable risk factors. So lower screening uptake and inconsistent primary care referral pathway contribute to a later stage at presentation. And for instance, this is one of the data where it shows that this dark brown is the stage 4 at the time of diagnosis. So you can see that in these Middle Eastern countries, so significant proportion of the patient are diagnosed at the stage 4 disease because of the less uptake of the screening program. So there are certain common barriers for the diagnosis of the colon cancer. For instance, there is lack of recommendation from the physician, and also there is a lack of awareness about the screening program that exists, like the FIT test or the colonoscopy. And there is certain fear about the pain of the procedure or the perceived invasiveness of the colonoscopy, and certain embarrassment also among certain population. And some people have the belief that I am not at risk because I don't have any symptom, there is no family history, and there is a healthy lifestyle which is sufficient, and I should not undergo the screening process. And there are certain health system barrier, for instance, inadequate guideline in some places and inconsistent referral from the primary care center for the colonoscopy. So this is the data from the UAE, so where there is a stringent screening program exists. So you can see 45,000 people were eligible for the screening test, and only 10,000 people underwent the screening test via the FIT test and FOBT, and out of that 1,400 were found positive for the FOBT, but still only 436 patients underwent the screening colonoscopy, which is just 30%. So even if the screening test is carried out, they are not translated into a real-time colonoscopy to detect the disease at an early stage. So there are certain molecular and the genetic differences also exist in this particular part of the world. For instance, globally KRAS mutation is around 38%, but in the GCC it is more, which is 45%, and there is a lower BRAF mutation which is 2.5% compared with the 5 to 15% in the rest of the world, which has the therapeutic implication and a prognostic value. For instance, this is a Kaplan-Meier survival curve. You can see that the survival is significantly reduced with this mutated patients compared to the wild type. So several GCC centers still show a sizable proportion of the patient presenting with locally advanced disease, contributing to the higher mortality to the incidence ratio. However, survival is improving with the modern multidisciplinary oncology care and access to the targeted agent surgery and the surgery available. So there are different, the hypothesis why the incidence has increased, why there is an early onset cancer more in this part of the world. So as we know that the obesity and diabetes is highly prevalent in this part of the world. For instance, if you can see, this brown line here represents the Bahrain. The diabetes prevalence is around 15 to 18%. And if you see here the prevalence of obesity, so Bahrain ranked in 25 in the world in the prevalence of obesity, and similar trend is observed in rest of the GCC countries, which is a risk factor for the development of colon cancer. So what are the evidences and recommendation, practical policy and the clinical action for the GCC? They scale up an organized screening program, and the starting at an earlier age, particularly for those individuals who are the high risk, who have the family history of the colon cancer, and target the obesity and metabolic disease aggressively. The fiscal and environment measure to increase the physical activity and improve the diet. And the red flag sign whenever it is present, for instance, the rectal bleeding, persistent abdominal pain, or the change in the bowel habit, weight loss, iron deficiency should be screened irrespective of the age. And there should be shortening in the diagnostic interval and the diagnostic procedures. So the various screening tests which has already been discussed earlier by Dr. Najah, so I'll skip these slides, which include the FIT test and the DNA test, stool-based test with variable sensitivity and specificity, and the blood test. So there are high quality research in the cancer registries, and the studies are needed, particularly in the GCC, to understand the unique pattern of the disease in these countries. And there should be a precise there should be a large case control, and the cohort studies are required to understand the attribution of the early onset colon cancer, and the population scale screening cost effectiveness studies are tailored to the GCC demography and healthcare costs to decide the threshold and the age of the screening. So in conclusion, the colorectal cancer is emerging and the growing global health problem, and rising incidence alarming in the GCC countries also. And there is a need to scale up the organized screening program and prioritize the lifestyle and metabolic risk reduction, and improve the early referral for the symptomatic patients irrespective of the age. And extensive local research is needed for the better understanding of the tumor biology, and the coordinated public health and clinical strategies could substantially blunt the projected rise in the CRC in the Gulf countries. So these are my key references. Thank you.
Thank you, Dr. Mansour, for sharing those important regional insights. Now, before we move on, we would like to take a moment to acknowledge our sponsor for tonight's program. We truly appreciate their support. And we encourage all of you to visit their booth anytime throughout this evening. It's located near the entrance. And also, we would like to kindly remind all the participants to fill up the evaluation form placed on each table, because this is very important to get your CME points. Now, moving on to our next session, which will focus on the surgical management of complicated colon cancer cases, where precision and advanced skills are essential. The speaker is a gastrointestinal surgeon with over 15 years of experience. His expertise covers gastrointestinal, hepatobiliary, pancreatic, and colorectal surgery, with proficiency in both open and advanced laparoscopic techniques. It is my privilege to introduce our distinguished speaker, Dr. Venkata Srinivas.
Ladies and gentlemen, good evening. So, as part of today's CME, I would like to discuss about surgical management of complicated colon cancer. So, here I will be navigating you through some of the complicated colon cancer cases, some locally advanced cancers, and review the surgical options and decision-making algorithms. And I will not discuss about rectal cancer, peritoneal carcinomatosis, or colorectal cancer, which is a different ball game altogether. So we know that colectomies in colon cancer are standardized, like depending on the location of the tumor, it might be right hemicolectomy, left hemicolectomy, transverse colectomy, sigmoid colectomy, or extended colectomies. But there are certain situations where complicated colon cancer might demand the surgeon to change their approach or modify their surgical approach. So complicated colon cancers usually deal with some emergency presentations like large bowel obstruction and perforation due to colon cancer, and locally advanced tumors like stage T4B, and some special situations like inflammatory bowel disease, bleeding, and hereditary syndromes. So coming to management of colon cancer with obstruction, up to 7 to 29% of newly diagnosed colon cancers present with obstruction, and among all these, 15 to 25% require immediate surgery. And the 90-day mortality is much higher than what we see in the elective surgery. And one thing which we had to stress upon is whenever there is a patient with colon cancer who presents with obstruction, the stage independent survival is worst. The overall hazard ratio is 1.79, and the 5-year survival is 42 to 51%, whereas when we compare colon cancers which are not non-obstructed, the overall survival, 5-year survival is 72, 75%. So this indirectly says that these patients are usually in advanced stages. So coming to clinical aspects, usually most of these patients present with like any other acute intestinal or subacute intestinal obstructions. But one thing we have to see is that among all patients with colon cancers, most of the left-sided colon cancers present with obstruction, whereas patients with right-sided colon cancers usually presents with bleed. And the preoperative workup is routine, like staging and risk stratification. Whenever a patient with acute colon cancer with obstruction has significant abdominal distension, vomitings, usually these patients might require some preoperative optimization before taking them for surgery, like placement of a nasogastric tube, correcting the electrolyte imbalance, etc. So right-sided obstruction, when patient has, usually we can get away with primary resection and ileocholic anastomosis, like right hemicolectomy, standard right hemicolectomy. Ileostomy is rarely added to these patients. But when we encounter a patient with left-sided colonic obstruction, there are two modalities. Either we can go for upfront emergency surgery, or we can opt for colonic stenting as a bridge before surgery. Usually in our clinical practice, up to 80% of patients we take for upfront emergency surgeries. So basically what is stenting, bridging before colonic cancer surgery? So in these patients, usually whenever there is an obstruction during colonoscopy, a guide wire is navigated through the strictured area and self-expanding metal stent is placed. So what are the advantages we see? What changes does it make in our surgical planning? Usually when a stenting is done before surgery, the proximal bowel, which is grossly distended, decompresses. So this allows sometimes the surgical decision to be altered. I mean, sometimes we consider laparoscopic surgery in these patients if there is a significant decompression. Sometimes we avoid stoma in these patients if there is a significant decrease in bowel wall edema and the tissue situation. So this is one X-ray which I have taken from my colleague. Same patient, patient with colonic cancer who presented with significant obstruction. So instead of going for upfront surgery, the treating team has opted for a placement of a metallic stent, after which there is significant decrease in the intestinal obstruction features. So this patient has ultimately gone for a laparoscopic surgery instead of open surgery. So as discussed, colonic stenting advantages are going for higher primary anastomosis rate and the lower stoma creation rate. But the notorious complications which we encounter during stenting is either stent migration, stent occlusion, or perforation. Out of all these three complications, perforation is seen in up to 9.5% of patients, and it is the most catastrophic complication one encounters when a stent is placed, because these patients who are already sick might end up in fecal peritonitis. Now, this is one of our patient whom we have operated a couple of years ago. So he is a seafarer, so he could not come to medical attention immediately, who presented with significant obstruction, large bowel obstruction. Here we can see a grossly distended cecum, and there is a small strictured area in the rectosigmoid. So we cannot take this patient for upfront laparoscopic surgery due to his abdominal distension. So we have gone for an open surgery, and when we see such bowel during surgery, quite edematous, quite distended, we can't opt for a primary anastomosis. So the simple bailout situation and the most preferred approach is to do a sigmoidectomy and do exteriorize the proximal bowel, which is known as Hartmann's procedure. This is another patient whom we have operated a couple of months ago. Patient again with colon cancer with subacute obstruction. He is not in frank obstruction. On plain X-ray itself, we can see that his colon is grossly fecal loaded. So without preparation, without any bowel preparation, we have taken up this patient for surgery, and we could complete the primary anastomosis laparoscopically. So here, two situations. Patient who presents with gross abdominal distension, significantly distended proximal colon, opt for a Hartmann's procedure, whereas even if fecally loaded, if patient is in obstruction but the healthy tissue is present, we can go for upfront primary anastomosis. So the emergency surgery advantages, instead of going for stenting, is there is a better long-term decompression. We can avoid the complications of stenting, and there is almost always 100% technical success rate. How about the surgical outcomes? In patients who has undergone for emergency surgery, the 30-day mortality is higher compared to patient who has undergone colonic stenting. This is because when we go for emergency surgeries, there is no adequate pre-optimization of the patient before surgery. Whereas if we do a stenting prior to surgery, we can optimize the patient, let the bowel decompress, and go for a primary anastomosis. So this would prevent the anastomotic leak rate, and the overall morbidity also decreased in these patients with colonic stenting. The only limiting factor is technical expertise. So even the NCCN guidelines recommend the same, that it should always be an expertise dependent recommendation. If there is an expertise for colonic stenting, do colonic stenting, then go for surgery. If there is no expertise, we can take these patients upfront for surgery. So coming to the next aspect, perforation. So this is one of the most catastrophic complications we encounter when we see patients with colonic cancer. Out of all colonic cancers patients, 3 to 10% have present with perforations, and perforation surgeries in colon cancers account up to 10% of surgeries. And the mortality rate in these surgeries is also quite higher. In a normal colectomies in cancer patients, the elective mortality is 2 to 3%, whereas this substantially increases up to 40% in patients with perforation. And the mechanisms of perforation might either be tumor necrosis and wall weakness, or it might be increased intraluminal pressure proximal to obstruction. We might encounter an obstruction at the rectosigmoid junction, but due to the proximal dilatation and due to the closed loop obstruction, when there is a patent ileocecal valve, we see closed loop obstructions, and we see that the perforation is not at the site of malignancy. The perforation will be well away and proximal to the site of malignancy. So the most common locations is sigmoid colon up to 40%, then comes the cecum. So there are two types of perforation. One is a free perforation, another one is a contained perforation. So free perforation is nothing but a generalized peritonitis where the bacterial load is quite high, because these patients are having a significantly loaded colon with fecal matter and which contains high bacterial load. As a result of this, when they perforate, there is a greater physiologic stress on the body, and these patients usually end up in systemic inflammatory response syndrome. So these patient mandates immediate surgery, and the 30-day mortality is quite high when we encounter free perforation. It's up to 26%. Whereas in contained perforation, it is usually a localized peritonitis or abscess. This is basically because of sealing of the perforation by the adjacent organs. And these patients have a less bacterial load, so they are more stable. Sometimes these patients can be optimized by a percutaneous intervention to drain the abscess, then optimize the patient, then take the patient for surgery. So the outcomes are quite different in patients with contained perforation and free perforation. Their 5-year survival and 30-day mortality are also better compared to free perforation. And the clinical presentation is like any other peritonitis cases, and usually radiological imaging is the one which clinches the diagnosis of malignancy in a patient with perforation. And coming to the timing, any patient who presents with free perforation, we have to go for immediate surgery. Take the patient as and how he is. But in patients who has contained perforation, as said, we can optimize the patient, do some abscess drainage, and then go for a staged procedure. The goals of surgery in patients with perforation is mainly source control and sepsis management, tumor resection whenever is feasible, and if the patient is quite unstable, go for damage control surgery instead of extensive definitive oncological procedures. So the surgical decision tree is hemodynamically stable patients, go for primary resection. If the intraoperatively tissue is healthy, go for an anastomosis. If the tissues are not healthy, divert the patient, go for a stoma. In hemodynamically unstable patients, do limited surgery, whichever is possible, like a damage control surgery. Suppose when we go for a primary resection, there are different approaches again. Either, as mentioned, you can go for a primary anastomosis or stoma, or sometimes extended surgical approaches. So when we go for primary anastomosis, what are the options? Should we go for a hand-sewn anastomosis or should we go for a stapled anastomosis? In low rectal surgeries, we don't have any other choice. We always go for a stapled anastomosis. But in other proximal surgeries, it's always preferable to go for a hand-sewn anastomosis, two-layered and interrupted. Don't go for continuous suturing, because this maintains the integrity of the anastomosis. And always try to add a defunctioning ileostomy proximal to the anastomosis. And there are some absolute contraindications for primary anastomosis. If a patient is hemodynamically stable, and if the patient is on vasopressors due to sepsis, or if there is severe peritoneal contamination due to fecal matter, and if the bowel wall is quite edematous or pre-ischemic, and if the patient is having significant comorbidities like ASA greater than 3. So these are all the absolute conditions where we always should prefer stoma instead of going for primary anastomosis. So Hartmann's procedure is one beautiful procedure where we can just resect the pathologic part of the colon and exteriorize the bowel. So this is the safest approach in high-risk patients. There is no question of anastomotic leak because the patient is already diverted, and it is a quite suitable procedure for unstable patients. The only disadvantage for these patients is permanent stoma in up to 60 to 80%. These patients, when we try to go for Hartmann's reversal, we see only 20 to 40% of patients will be fit enough to come back for surgery for a stoma closure. On the other hand, primary anastomosis does offer a better quality of life. It is a single stage procedure, but the only and the main risk factor is high anastomotic leak rate. Whenever there is anastomotic leak, these patients might come late for oncologic treatment or for adjuvant chemotherapy. So whenever there is leak, there is significant inflammation. Inflammation causes significant increase in the growth factors. These growth factors sometimes result in extensive metastasis in the later period. So right-sided perforation, go for right hemicolectomy, and left-sided perforation, two options, Hartmann's procedure or a direct primary anastomosis. So now, how are the outcomes in these patients? Usually, patients who have free perforation has poorer outcomes. Left-sided tumor location, poorer outcomes. When patients come late for surgery, there is a poor outcome. Only positive thing is if patients achieve R0 resection in a clean abdomen, the outcomes are better. So this is one of our patient where we have taken for perforation of the sigmoid cancer, and intraoperatively we can see extensive peritonitis. So we don't have any other option but to go for a Hartmann's procedure. Then this is another patient, a young Chinese patient with a huge mass in the transverse colon, came immediately after patient had pain abdomen, when we can see some specks of air in the peritoneum. So this patient, due to limited contamination, we have gone straight away for primary anastomosis. So next comes how to manage locally advanced colon cancers. So usually, by definition, any T4B tumor, that is tumor which directly invades adjacent organs or structures, is defined as T4B cancers. Previously, these cancers were considered to be inoperable, but now with the advent of multivisceral resection, like en bloc resection of the tumor with adherent organs, the improved survival is achieved, and if at all in these patients we achieve R0 resection, it is like any other patients, the 5-year survival is 50 to 70%. So the commonly involved organs are the bowel and the or small bowel and the bladder, and there are different types of invasion. It might be either due to direct tumor invasion or due to desmoplastic reaction and fibrosis, or sometimes it might be a just inflammatory adhesion. So when we subjected these specimens for histopathology, in literature it has been documented that only 40 to 70% of patients actually had true invasion. The rest were all inflammatory adhesions. So these patients sometimes present with organ-specific complaints, like whenever patient with colon cancer develops hematuria, we have to suspect bladder involvement. Whenever patient has recurrent colicky abdominal pain, obstruction, we have to suspect sometimes small bowel involvement. And in females, if there is a pelvic pain, vaginal bleeding, we have to suspect gynecological involvement. So there are certain challenges in evaluating these patients for multivisceral invasion. Imaging cannot distinguish whether it is a true invasion or whether it is an inflammatory adhesion. So sometimes imaging understages by 15 to 20%. On the other hand, in some cases, it overstages by 5 to 10%. Leaving alone the radiological assessment, even the intraoperative assessment sometimes is quite unreliable, because we cannot dare to breach the tissue planes when we contemplate these surgeries. Once we breach the tissue planes, it's like we are spreading malignancy. So regardless of whether we suspect inflammatory adhesion or a true invasion, we have to consider complete en bloc resection in these patients. So right-sided lesions like from cecum, ascending colon, they usually tend to invade duodenum or the right ureter. And these patients have to sometimes undergo even pancreaticoduodenectomy when there is invasion of pancreatic head and duodenum, which are quite morbid procedures. And left-sided lesions from descending colon or sigmoid cancer, they usually infiltrate urinary bladder or uterus and adnexa. And sometimes left ureter is involved when there is pelvic side wall involvement at the ureteric brim. So these patients, apart from left hemicolectomy, might need hysterectomy or salpingo-oophorectomy, and sometimes partial removal of the urinary bladder cuff as well. Whenever we suspect left ureteric or right ureteric involvement preoperatively, we always have to take the help of the urologist. We can go for a preoperative ureteric stenting. This might either help in preventing the injury of ureter during our dissection, or if there is a direct involvement, it will guide us to the next step of ureteric reconstruction. So as expected, all multivisceral resections, they have high morbidity and mortality because they are quite extensive surgeries than the normal standard resections. And how are the oncologic outcomes? The 5-year overall survival, if we achieve R0 resection, is 50 to 70% like any other standard colon cancer. But the only disease-free survival is 40 to 55%. Because these patients are usually having an aggressive tumor biology, these recurrence is usually expected in these patients. But instead of local recurrence, on the contrary, we see these patients have distant recurrence. Local recurrence is only 10 to 15%, but distant recurrence is 30 to 45%. This is because during surgery, en bloc resection helps us in dealing with the macroscopic spread of the disease. But the microscopic spread, which has already been there due to aggressive tumor biology, is not addressed. So distant recurrence rate is quite high in these patients. And compared with standard resection, if R0 resection is achieved, we can be sure that there will be a similar survival. So this is one of our patients where preoperatively we did not suspect sigmoid cancer, preoperatively we did not suspect a urinary bladder infiltration, but intraoperatively there is adhesion to the urinary bladder and we had to do a sigmoid colon resection with removal of the dome of bladder. And fortunately this patient only adhesive infiltration is present. So even the current guidelines like the NCCN, whenever possible, if R0 resection can be achieved, we can consider all T4 tumors for en bloc resection. And now some recent trials are coming up where neoadjuvant therapy can be considered in limited patients, and the primary goal, whatever, should be R0 resection. Now, of late we are seeing a different set of patients due to increased incidence of diverticulosis. So diverticulosis is present in 5 to 15% of colon cancer patients, and the coexistence may complicate diagnosis and treatment. We see both these conditions with increase in the age of the patient, and there is a definite temporal relationship which is established between colon cancer and between diverticulitis. So there is increased colorectal cancer risk in the first 6 months post diverticulitis episode. This is again due to inflammation causing release of growth factors increasing the chances of carcinogenesis. And all patients with diverticulitis, there should be a follow-up colonoscopy essentially 6 to 8 weeks post-acute phase. So clinical presentation, there are certain overlapping symptoms in both these entities, like abdominal pain, change in bowel habits, and rectal bleeding. They are seen in both diverticulitis patients and in colon cancer patients. But there are also certain differentiating features. Usually colon cancer patients have progressive symptoms, progressive weight loss and anemia, whereas acute diverticulitis patients, they have sudden onset acute pain, fever and localized tenderness. Main challenge comes in diagnosis of these patients, like the inflammation always masks early cancer signs. There is false positive imaging even if we suspect cancer because of wall thickening, which is also seen in diverticulitis patients. And there is always difficulty distinguishing whether this patient is having a diverticular stricture or whether this patient is having a malignant stenosis. So colonoscopy and biopsy is the only option to differentiate this, but this is challenging in patients with inflamed tissue in case of diverticulitis. So this is one of our patients. Unfortunately, today colonoscopy was done for this patient. She's a Qatari lady who has the known patient of diverticulitis, recurrent diverticulitis since 10 months. She has been admitted multiple times and managed conservatively for the so-called diverticulitis. But today when colonoscopy is done, unfortunately this lady has an ulceroproliferative growth and staging has shown that a suspected lung nodule. So only the PET will answer whether this is already a metastatic disease. So what is the impact of diverticulitis on colon cancer surgeries? Usually if there is a colon cancer, we always go for segmental colectomies. But when there is a patient has diverticulitis or previous diverticulitis episodes, the distal colon or the proximal colon, apart from malignant lesion, might not be suitable for resection and anastomosis. So these patients might need extended resections, which might increase the operative time, and there are always higher conversion rates when we contemplate laparoscopic surgeries. So the increased conversion rates up to 25% we see when we contemplate laparoscopic colectomies in patients with diverticulitis. The technical difficulties we encounter as a surgeon is because of limited visibility due to inflammation, and the other thing is altered anatomy from previous diverticulitis episodes. There might be dense fibrosis which obscures planes, and there is always a difficulty with retraction and exposure. So whenever we encounter these type of difficulties on table, we always try to start our surgery from a normal plane to an abnormal plane. Sometimes we also change our approaches. Instead of medial to lateral approach dissection, we come from lateral to medial approach. So on table decision is quite important when we encounter such issues. If that is not possible, then we have to convert these patients to open surgeries. So, and coming to anastomotic considerations, as already discussed, if there is a healthy tissue, we can go for primary anastomosis. Unhealthy tissue, exteriorize the proximal bowel and do a Hartmann's procedure, and always try to add a defunctioning colostomy. The main issue we encounter whenever we come across with extended colectomies is restoration of bowel continuity, like how to join the two dissected and transected colons. So this is one of our patient where patient had a splenic flexure perforation, and distally there is a significant diverticulitis of the descending colon and the sigmoid. So this patient ended up in left hemicolectomy and sigmoidectomy. Sigmoidectomy has to be done because the distal bowel is quite affected with significant diverticulitis episodes in the past. So this bowel is not suitable for anastomosis. So ultimately, due to intraoperative contamination, we have to exteriorize this patient. Now when we exteriorize this patient, what about our second surgery, like how to restore the bowel continuity? There are two transected ends quite far apart. So tension-free anastomosis is a big question in this patient. So there are certain approaches where we can join the transected ends, like two surgeries like the retroileal colorectal anastomosis, which is also called as Turnbull's procedure, or the second approach, the Delroy's procedure. So basically what we do in this procedure is we transect the colostomy, we identify the terminal ileal mesentery between the superior mesenteric vessel and the ileocolic vessel. This is a pictorial diagram. So we essentially create a window between these two vessels, and we pull the transected end of the colon through this window and join the rectum. So this intraoperatively we had created a window between the right ileocolic vessels and the mesenteric vessels on the medial end. And after pulling the transected colon, we have to ensure that there is a tension-free anastomosis between both the rectal stump and the proximal colon. So this is the pictorial depiction. Now suppose if even this is not possible, then we are left with another procedure called the Delroy's procedure, which is quite complex and morbid. In this, whenever tension-free anastomosis is not possible, the only option left for us is to flip the colon 180 degrees is in counterclockwise direction and anastomose it to the rectal stump. But the main disadvantage or main risk which lies in these procedures is this mesentery rotation might cause vascular thrombosis or mesenteric ischemia. So always the anastomosis is at the mercy whether the blood supply is there or not to the transected end of the colon. So in such cases, even if this is not possible, then the only option left with us would be to go for a total colectomy and ileorectal anastomosis. And there are some other special situations where we encounter bleeding. 1 to 15% of colon cancers might present with bleeding. And in lower GI bleeds, massive lower GI bleeds, 6% of patients are due to colorectal cancer. So whenever we encounter patients with massive GI bleed, it is like any other GI bleed management. So if the patient is stable, go for primary resection and anastomosis. If the patient is unstable, go for a damage control surgery and extravase the bowel. This is a peculiar case where there is a bleeding malignancy, bleeding lesion. Though the lesion is not troublesome, the situation has made the clinical scenario more complex. So this is a 120 kg weight guy with a BMI of around 45. So he presented with dyspnea, and when workup was done, he had a embolus in the right pulmonary artery. So this is a patient of pulmonary embolism. So when he was started on anticoagulation, patient had a massive lower GI bleed. And when CT scan was done, it was shown to have a suspected colonic lesion, and a colonoscopy showed that there is a bleeding tumor. So this patient straight away, in the presence of therapeutic anticoagulation, we had to take this patient for laparoscopic right hemicolectomy. The options in this patient available is either we can go for preoperative IVC stenting to prevent the thrombosis risk after surgery, or whenever it is not feasible, we don't have any other option but to go for upfront surgery in this patient. And there are some, coming to the last session, last details, there are some special situations in colon cancer surgery which makes the situation more complex, like hereditary colon cancers. Lynch syndrome, we see 25 to 30% have synchronous cancer lesions, whereas FAP nearly 100% we see that these patients in future develop colon cancer malignancy. So surgery in these hereditary syndromes would be a total colectomy with or without proctectomy. So when we do proctectomy, we have to do ilioanal pouch anastomosis, but when we save the rectum, we can directly go ahead with iliorectal anastomosis. So this is one of the patient whom I operated, and this is a young female who presented 1 week after her marriage, unfortunately had a large sigmoid growth. So this patient, when colonoscopy was done, has her colon studded with polyps. So this patient, ideally we have to take this patient for a total colectomy with proctectomy as well. But because of social situation, like young patient, to preserve her fertility, we had to preserve her rectum and take the chance of total colectomy. And this patient should be on strict surveillance for her rectal polypoid lesions. This is another patient whom we operated couple of months back, an Italian guy who presented with rectal cancer, rectal bleeding, and on colonoscopy, his colon is studded with polyps. Even this patient, we had counseled for proctectomy, but patient was quite adamant in view of his personal reasons, because usually whenever patient undergo proctectomy, there will be a significant sexual dysfunction chances in these patients. So he has opted for total colectomy and rectal anastomosis. So coming to total colectomy and subtotal colectomy, apart from segmental colectomies, there are specific indications, like whenever there are bilateral synchronous colon cancers, whenever there are multiple adenomas with high-grade dysplasia, in patients with hereditary syndromes, and in patients with inflammatory bowel disease like ulcerative colitis with colon cancer. All these patients usually have a field defect. So isolated segmental colectomies will not serve the purpose. These patients has to be considered for extended colectomies, mostly total colectomies, to prevent the future risk of malignancy. So my take-home message is, complicated colon cancers often pose therapeutic challenges. They require individualized approach, and multidisciplinary approach is recommended. Most of them require emergency surgeries which has higher risks but are often necessary and mandatory. And the main goal whatsoever should be R0 resection to achieve good oncological outcomes. Thank you.
Thank you, Doctor, for that insightful surgical perspective. Now, moving on to our next session, which focuses on the evolving standards of care in localized colon cancer, particularly the role of adjuvant and neoadjuvant treatments. The speaker is a highly accomplished oncologist trained at the Armed Forces Medical College in Pune and specialized in medical oncology at the Rajiv Gandhi Cancer Institute in New Delhi. He holds international qualifications, including the European Certificate in Medical Oncology and MRCP in Oncology UK, with expertise spanning solid tumors, hematological cancers, targeted therapies, and immunotherapy. It is my privilege to welcome our distinguished speaker, Dr. Chaturbhuj Agrawal.
Thank you very much. And I already got red signals. We are very late, so I will be quick and relevant. So my job starts after surgery, and we all know there is very little role of neoadjuvant chemotherapy in colon cancer. So we will quickly go through the agenda. So there are only few things which has come up in last decade. This was presented in ASCO 2025. So I will go through 6 headings: introduction and what is the rationale of adjuvant chemotherapy, treatment selection, duration and toxicity, because that is the most important aspect when it comes to adjuvant chemotherapy, molecular testing, because lot of new role is coming up with MMR and PIK3CA testing, which Dr. Mariam also tried to explain us. And there are few immunotherapies which are now finding their way in adjuvant setting, not only in metastatic setting. And finally, take home message. So first part is introduction. What is the role of adjuvant therapy? So adjuvant therapy is basically given to eliminate all the micrometastatic disease, and we all know that there are certain stage 2 and stage 3 cancers which has high degree of high chances of recurrence, and we give systemic therapy to prevent recurrence. Improving adjuvant therapy, the way forward is not clear because we want to achieve cure for all the patients with residual micrometastatic disease, but on the other hand, we want to treat only those who will benefit. So most important part is individualizing the therapy. Treat with the right drug, treat with the right duration, and minimize the toxicity. Because when it comes to adjuvant therapy, we always want to give the medicines which are exactly needed, not more, not less, and to discover new treatments. So these are the ways we are looking forward. This is a very important slide which was way back in 2009 by very senior colleague Gunderson et al. So if you can see one important point, what I wanted to show from this slide is, if somebody has a T4 disease, even if it is node negative, it has got really bad prognosis. And if you see 5-year overall survival, it was much better, even if it is T2N1 or T3N1. So T4 tumors are perhaps the most worst tumor, even if they are node negative. And adjuvant chemotherapy for colon cancer, particularly in stage 2, it fails 95% of the time. When I say it fails 95% of the time, I'm not telling recurrence. I'm telling because most of the times either we are under-treating or majority of the times we are over-treating. And this was the thing which we tried to clear in the last decade. Which patients of stage 2 colon cancer actually needs treatment? So do we have any genetic assay like Oncotype DX, which we used to do in breast cancer? So Oncotype DX was validated as a prognostic index, but it does not offer any predictive information when it comes to colon cancer treatment decision, particularly in stage 2 and stage 3. So when we do the surgery, after R0 resection, we get our patients from the surgeon. The optimal window is to initiate 6 to 8 weeks post-operatively to obtain the maximum benefit. And any treatment delay beyond 8 weeks of surgery will definitely compromise outcome. And the factors which delay this are surgical recovery time, sometimes system insufficiencies, and patient comorbidities. So coming to chemo regimen, who are the fit patients? Are we going to give oxaliplatin to all patients? And what is the ideal duration of treatment? These are the 3 basic questions. So is oxaliplatin is for everyone? We know that oxaliplatin benefit is minimum, but it increases as the stage increases. So oxaliplatin benefit is more and more in node positive cases. And now we are trying to divide patients into 2 parts, low risk and high risk. And for low risk patients, we are trying to omit oxaliplatin because we know patients who are under 70 years of age, who are medically fit without any significant comorbidities, they can receive oxaliplatin. It has demonstrated clear superiority, particularly in the high risk group over 5-FU monotherapy. And oxaliplatin has demonstrated superiority, particularly in the patients who are MMR, unstable or MSI high. Folfox, we all know this landmark trial, Mosaic trial. So somebody comes with colon cancer post-op, you give Folfox, particularly in stage 3. There is 10-year overall survival of 67%, which is very good. There is 13% incidence of grade 3 neuropathy, but mostly reversible with appropriate management. If we come to Capox, the another regimen, the convenience is it's an oral tablet, so patient has to come once 3 weekly for oxaliplatin injection and he goes back with capecitabine. And in Bahrain, we are giving more and more Capox rather than Folfox. IDEA collaboration has established non-inferiority of 3 months of treatment in low-risk subset. There is a distinct toxicity profile. Patients that tolerate Folfox much better. Particularly if there is, if the patients, they have issues with 5-FU, infusional 5-FU, or they don't want to come for infusional therapy. But yes, there is higher incidence of some symptoms like hand-foot syndrome and peripheral neuropathy. But obviously reduced neutropenia and reduced cardiotoxicity. Now, what is the ideal duration of treatment? So I will quickly go to the IDEA trial. So the IDEA analysis has shown for low-risk colon cancer, 3 months of Capox is non-inferior. So now what we are doing is we divide our patients to low risk versus high risk. For low risk patients, we just offer them 3 months of Capox, not Folfox. And this is the duration of doublet adjuvant therapy. But to remind, for this non-inferiority was not proved with Folfox. It is only with Capox. So if we are giving Folfox, we have to complete 6 months of therapy. So this is the IDEA collaboration, which this slide we will see in the end. So this is the duration of oxaliplatin and early discontinuation of oxaliplatin. If some patients develop neuropathy, it has no significant difference in OS or DFS. So if we start with FOLFOX, if patient develops oxaliplatin, maybe after 8 cycles, we can discontinue oxaliplatin and continue 5-FU leucovorin. Monitoring oxaliplatin neuropathy, we take help of our neurologist. We assess neuropathy severity before each cycle, and we discontinue oxaliplatin if there is more than or equal to grade 2 neuropathy. And obviously, we continue 5-FU to complete 6 months. So early oxaliplatin discontinuation does not compromise treatment outcome, as we have seen previously. Now, last few slides on mismatch repair testing. We all have seen multiple times since the start of this meeting that MMR testing is very important in colon cancer. Deficient MMR patients, they do much well as compared to proficient MMR patient. However, they are resistant to 5-FU monotherapy. That's why we tend to add oxaliplatin in this subset of patients. Now, the most important part of this presentation, which is update from this ASCO 2025, is PIK3 mutation testing. If we talk of last year, we tend to complete our chemotherapy and send our patient back, and we keep them on follow-up. Now, there are two things which has come up. One is PIK3 mutation testing, and second is circulating tumor DNA. So PIK3 mutation testing, we should test all our adjuvant patients for PIK3 mutation. PIK3 mutation are observed in around 15 to 20% of colorectal cancer, and they predict aspirin sensitivity. And if you see, if somebody is PIK3 mutated, there is a huge difference with aspirin. So once you finish your adjuvant therapy, if somebody is PIK3 mutated, you offer them aspirin for 3 years, 100 to 160 mg OD, there is a huge difference in recurrence. Because PIK3 mutation, it activates PIK3 mTOR pathway, which leads to activation of COX-2, which activates prostaglandin. Prostaglandin activates angiogenesis and tumor proliferation, and aspirin will probably inhibit this cycle, particularly in patients who are PIK3 mutated. So now this is something new which we are going to adopt this year. Microsatellite instability, we had a lot of discussion. There is one trial, atomic trial, which has shown that if patient is MSI high, then you should combine atezolizumab for total duration of the FOLFOX. So it has huge difference. Again, if you see the atomic trial, addition of immunotherapy to adjuvant FOLFOX has given a lot of good difference. So 86% in the atezolizumab arm versus 76% in the FOLFOX arm. But this was only in MSI high group. So this is something new which we learned this year. So less fit patients, we have to give fluoropyrimidine monotherapy, but monotherapy should be avoided in deficient MMR subgroup that we have seen. What not to use, that is also important. Irinotecan, it has no role in adjuvant setting. However, we use it very frequently in metastatic setting. Targeted therapies like bevacizumab, cetuximab, celecoxib, we still don't have any role. Celecoxib, they tried celecoxib in anticipation that when aspirin works, celecoxib will also work. However, SWOG trial, celecoxib was not shown any benefit. The reason because celecoxib was started after the completion of adjuvant therapy, while in the aspirin trial, they started aspirin with chemotherapy. So probably that is the reason. Loco-regional therapy, I will skip because Dr. Munthir will have a very extensive presentation on liver-directed therapy. The last part is, what is the role of CTC? So when we finish adjuvant chemotherapy, we send our patient back and we tell them to come every 3 months. Dynamic 3 study evaluated that can we predict recurrence? So suppose if at the end of treatment response, you do circulating tumor cells, if somebody's circulating tumor cell positive, so then the recurrence-free interval is 84%. So 84% chances of more recurrence as compared to 12% for those who achieve circulating tumor cell free at the end of adjuvant chemotherapy. The sad part is the recurrence rate was not significantly reduced when, because of this information, even we escalate the treatment. So circulating tumor cells are prognostic, not predictive. On the basis of this information, we can only tell the patient is at high risk of recurrence, but we cannot escalate the treatment. So this is the normogram which we are following, and I will quickly come to the ASCO guidelines. So whenever we see patient with stage 2 colon cancer, we see if they are without high risk features, we don't offer them adjuvant chemotherapy, particularly if they are DMMR. Patients with high risk features, we offer them 5-FU based therapy if they are low risk, particularly N1 disease. And patients who are T4, stage 2B, stage 2C, they are particularly high risk, particularly if proficient MMR. So we have to offer them complete 6 months of therapy as shown in IDEA trial. We cannot subject them to less intensive chemotherapy regimen. So this is the take-home message. the key take-home message, PIK3 and MMR mutation should be done for all patients. We have to personalize based upon molecular marker. If somebody is deficient MMR, we can offer atezolizumab. If somebody is PIK3 mutated, we have to offer aspirin. Only chemotherapy is not enough. And for fit patients, oxaliplatin is to be preferred. 3 months for low risk, 6 months for high risk, and atezolizumab for deficient MMR. Thank you. Thank you.
Thank you, Doctor, for that very comprehensive session. Now, moving on to our next session, this will take us into one of the most exciting and fast-evolving frontiers of cancer care, which is immunotherapy. The speaker is a medical oncologist with over 15 years of experience, currently serving as the consultant medical oncologist at King Hamad University Hospital and the Bahrain Oncology Center. In 2023, he completed his PhD in basic oncology and immunology. He has also pursued advanced training through the European Society of Medical Oncology in colon cancer and immunotherapy, and completed specialized program at Harvard University in immunology, immuno-oncology, and precision oncology. He brings deep expertise in tailoring innovative treatments to improve patient outcomes. It is my honor to introduce our distinguished speaker, Dr. Tarkan Yetishayed.
Good evening. Thank you so much. We are a little bit late. I will thank first the organization to invite me as a speaker. It is a pleasure and honor to have a presentation in front of senior doctors. Thank you. My presentation is easy, I hope. I will discuss actually a little bit a different topic. We will discuss the metastatic setting and immunotherapy, the future of the colon cancer, question mark, yes or no. I will say yes and I will say no. We have in cancer treatment different treatment options. Hormone therapy is not included for colorectal cancer, but overall we do surgery, we do transplant, we do chemotherapy, we do targeted therapy, we do radiation therapy, we do immunotherapy. How we came to that point, that is the cancer hallmark, which changed again in 2023. We included new frontiers like non-mutational epigenetic reprogramming that I will ask also Dr. Mariam Fida about that later on. Avoiding immune destruction, that was very important, which lead to us to the immune checkpoint inhibitors. Because we learned with that point that the tumor cells is anyhow avoiding from the immune cells, from the immune destructions. And how they did, they used first of all the tumor microenvironment, which is very important for us, and also later on we discovered that the checkpoints are very important. So other topics I will not jump yet. This is now the current approach in metastatic colorectal cancer. We started with chemotherapy. 5-FU was our backbone of the treatment. Then we add oxaliplatin or irinotecan to the treatment. It was the beginning of 2000, where we reached with that combinations around 14, 15 months overall survival. As a single agent, our target was 12 months median overall survival. It was only with 5-FU. Then, unfortunately, we were able to add anti-VEGF and anti-EGFR treatments, which lead to around median 24 months of overall survival, which was actually good for us. Then we discussed which one to use, anti-VEGF, anti-EGFR, right colon, left colon. That was the main topic in the beginning of 2010, 15. We had studies. Unfortunately, we end up later on. We can use this one. I will talk later on. This is not my topic. Where we will concentrate is in that small area now. What I am going to talk is MSI high, MSI plus other mutation, and POL-E mutation. My part is this part only 2 days. That's why, is it the future? Yes, for some patients, not for all patients. So, for which patient, we discuss how to define mismatch repair deficiency. I will not go through that slides. I will go more on that one. In the early stage, it is a little bit higher, the incidence, but unfortunately in stage 4, we have around only 4% patient of that one. And as Dr. Chaturbaj also mentioned before, actually this patient population are doing better if you have MSI high. What was the reason? We know that if you have a MSI high mutation, especially this mismatch repair GAN deficiency, we learned that we have more mutation, hypermutated tumor is in front of us, which will cause more neoantigen, which will our immune system activated with that mechanism. In 2010, people came together, said what we can do, We have a target, a biomarker. It is prognostic, but can we target that one? They thought different mechanism which we can target MSI high tumors or deficient mismatch repair genes patient population. Unfortunately, in 2013, a group said, let's do, these are hypermutated cancers. Maybe we can use these checkpoint inhibitors, which was already a treatment in melanoma, started with melanoma, but they decided to do a study, especially in metastatic colon cancer who had hypermutated colon cancer and non-colorectal cancer. They used single agent nivolumab, that was the drug nivolumab. That was the study, the first study, which showed us actually using this single agent in several lines treated patient had a response around 57% response rates and disease control of 90%. You will say, Tarkan, green is the deficient patient population, red is the proficient. And if you have this mutation, you are doing well. And from that, we started to do studies. Nivo was the frontier, and then pembrolizumab did his studies. Tislelizumab, dostarlimab was the next line. And overall, when we use these drugs, single agent, checkpoint inhibitors, we had overall response around 30–40%. And then we started to talk about curing. Can we cure this disease? I will discuss yes and again no. That was the first study where we used Keynote 177 was the first study where we used chemotherapy versus immunotherapy in the frontline first setting of metastatic colon rectal cancer. When you look, this is a single drug, but when you look the investigator choice, what we discussed before, REFT, LIGHT, FOLFOX, FOLFIRI, because everybody has a different practice. So many other arm was there with different chemotherapy combination. And then in this study, they also give the chance to the patient who were in the chemotherapy group, if they progress, to switch pembrolizumab. It makes a study difficult when you have an OS endpoint, because you are giving also, you are doing a cross over to the other drug. It is always difficult to have a crossover drug or study which have an overall survival outcome. So, is it working in all cases? No. Because this is the first, when you see on back side of me, this is the 40% of the patient population will progress in the first 4 months with a single agent immunotherapy treatment. That means, but if I look in the end of the follow-up, overall survival data, you remember I started with 12 months, 14 months, 24 months. With the combination new targeted, we reached to 36 months overall survival. But now with immunotherapy, single agent overall survival, I'm talking here 50%, they are still alive 68 months. What we saw in the other analysis, what we are checking is the overall response. Overall response, the main factor is, do we have complete response? Yes, we are seeing around 70% complete response. And 45% overall response was seen in that study. Of course, immunotherapy, when you give immunotherapy, you have different side effects. I will not dive deep in the side effects. It is immune-related side effects what we are have a different category and assessing differently and treating also differently. So when we looked at the subgroups, okay, which population have benefit, which not? Can we define the patient population who really were not having the benefit more? And it was actually this group, KRAS and NRAS mutated population, which we are seeing here also again. This population didn't work well comparing KRAS and NRAS wild type. So, checkmate, of course, we have pembrolizumab, and the competitor is always Nivo plus IPI. Checkmate 8HW study was designed. Here they had 3 arms, and as you see, they chose also 2 protocols with BEV and cetuximab standard protocols what we were using. First arm was Nivo, single agent, but the second arm is different because here you are combining 2 different checkpoint inhibitors. One is a PD-1 inhibitor and the other one is a CTLA-4 inhibitor. This is an amazing slide. Here behind me you can see that they are separating very fast. This is the progression-free survival data comparing chemo, Nivo plus IPI, the combination arm. When you see the progression-free survival data after 31 months, people are saying for this graph, pelican graph, this is the head of the pelican. After 47 months follow-up, still we didn't, almost we reached to 54 months progression-free survival. I'm not talking here overall survival. It will be much more longer. Still, we don't have the data. And overall, in each group here, we're seeing the benefit. Here also, they checked also RAS mutation, and the RAS mutation was not a prognostic or predictive factor in this case. We had better response. Overall response was 71 months here with the combination arm. We had side effects. As I mentioned, these side effects are a little bit different. Sometimes you have grade 3, grade 4 side effects. And when you stop in this patient population, if you have grade 3 and grade 4 side effects, still these patients are doing very well. And then what the discussion, which patient has to use combination, which patient has to start monotherapy. Some of the authors decided that, yes, maybe if the patient has a high volume of the tumor, can take that one. Age is a factor. See the other problems. That was designed for that situation. But the preference when you see the guidelines is Nivo plus IPI combination. I will jump closely with the mismatch repair disease in the early stage. Of course, when we have a good treatment in the metastatic setting, we are jumping directly to the earlier stage. Can we cure patients more and more? Here, is chemotherapy needed was one of the questions. Is adjuvant or neoadjuvant better? Which PD-1 monotherapy or combination we have to use? Should organ preservation be our main goal? And in the neoadjuvant setting, how we have to assess this patient population? Do we need to do CTs or something else? Briefly, neoadjuvant, adjuvant, we know that from the melanoma studies that if we have the tumor in the field with the microenvironment, when we give neoadjuvant treatment, we have a better outcome. That's why we did the studies also in colon cancer. Sorry, I included the NICHE-2 study. It is an early setting where we give ipi-nivo. Here I will tell you on one thing. It is one cycle combination, only one cycle combination, plus one nivo more. That means you will give 2 times nivo, once ipilimumab. And you can see, these are all cases, each line that you see, they included 111 cases in that study. 68 cases were complete response with only this combination for a short period. And the other overall response was amazing. We saw the data in ESMO. It was amazing. Everybody was looking, it is curable. It looks like curable. And then other studies came from the other groups. They did also, Overmans and his team did a study also. Can we protect patients to be done surgery in this population? It is not a big group. It is a small group. They included total, I guess, 10 patients or 11 patients, if I'm not wrong. And the comparison overall survival or disease-free survival, if you do surgery, if you not do surgery, was same. This is the magic drug, dostarlimab. Since 2022, you will see in the social media this drug. They started with rectal cancer. You can see all these blues are the rectal cancer. There is 100% response. And then they implemented to the other cancer who has this deficiency of mismatch repair gene. Urothelial worked, hepatobiliary worked, colon worked, gastric, yes. And it is working, but not in all cancer because there are some other mutation and other problems. So now currently it is in our guidelines. Also in the early setting, if we have a mismatch repair, again, for the rectum, we are recommending to give neoadjuvant, and we have cases that we treat in that, it is a little bit wrong. So, atomic you already discussed, I will not jump to that one. Radiologic assessment, okay. If we have a tumor and we started immunotherapy, and that was the baseline CT, and when we look at that, we saw it is actually growing more on the CT, and the report came out as it is growing. The impression is there is progression. But when you do a colonoscopy in that case, you will see the response. And after a while, if you complete the treatment, you will see there is no evidence of disease. That's why assessing, they are recommending, please doing, in these cases, also a colonoscopy. It is not enough to do only CT because it can be a pseudo-progression. So, very last, what is the future? Is it only these drugs? No, we have, as we mentioned, as Dr. Mariam Fida mentioned, that these are frame shift mutations. And the people said, okay, it is a standard mutation. We can make a pool. We can make from that a vaccine Now these studies are ongoing, vaccine plus immunotherapy, and it is having good response. You can see most of the patients getting benefit from that combination. This is the new trend. We will hear about that. Microbiota is actually a topic, a huge topic that we have to discuss maybe next year in this meeting, because it needs to be discussed. Microbiota has huge effect of our immune system, of the disease, of the progression. They did fecal transplant in some cases. From which cases they took the fecal transplant? Who responds to immunotherapy? They cleaned the colon, they give the fecal to the new patient, and then they treat again with immunotherapy. And what they saw was some patient had complete response. So in conclusion, Nivo-IP is the standard frontline treatment in metastatic setting. Neoadjuvant approach, please, we have to check also in the early setting MSI high status or mismatch repair situation, if it's proficient or deficient, we have to think of immunotherapy. Non-operative approach is important. We have to give the chance to our patients. Yeah, thank you so much. Regarding POL-E, Burçak, POL-E is also a mutation which is causing hypermutations. And it is an explorative analysis of the studies. They didn't do a standard study to say POL-E mutation will also get benefit. But when they made a meta-analysis, they find this mutation is also from the endometrium. We are learning this information. These patients are also doing well, is better to use. That's why they included explorative. It was in this 2025 NCCN. I can get questions or I can.
Thank you so much, Dr. Tarkan, for that insightful presentation. Now, moving on to our next session, which will highlight the vital role of interventional radiology in both diagnosing and treating colon cancer. The speaker is a senior consultant, diagnostic, and interventional radiologist with over 2 decades of experience. He has pioneered advanced interventional services in Bahrain, including oncologic interventions and the nation's first private stroke intervention program, and is a founding member of the Bahraini Society of Vascular Interventional Radiology. Please help me welcome our distinguished speaker, Dr. Munder Suela.
Assalamu alaikum. Hello and welcome, ladies and gentlemen. And thanks again for the invitation. I would like to go quickly and talk about my objective for this talk is to talk about the radiology influence in the journey of colon cancer treatment, highlight the role of IR, interventional radiology, with the strongest evidence and clear indications for when to refer and how to refer for IR, and show the value of a multidisciplinary team in the management of colon cancer patient. So I think a lot of these have been gone through in the previous talk, so I'm gonna skip through them, how to diagnose the disease, the incidence from research, and what is the percentage of cases in Bahrain, and go directly to the role of IR. So in general, IR is a tool that is to provide excellent care to the patient and to treat the symptoms. We know that the patient gets diagnosed with biopsies during colon and then for the plan of treatment. And IR provide a wide range of therapies that are given to patient, including the biopsies, boards, relief of obstructions with stenting, treating of acute bleeding, and liver-directed therapy for metastasis. Also to provide drainages for biliary obstructions, to provide drainages for abscesses, and injection of bleeding pseudoaneurysm secondary to the tumor. So the main role of IR is minimally invasive, image-guided, non-intrusive type of surgery. So again, the diagnostic dilemma that happens with colon cancer is that there are polyps that usually are diagnosed with colonoscopy, but on occasions, some patient will go and undergo colonography, like in this case. And the first role of IR is to provide an access for, I think the main role is chemo port insertion for treatment of providing chemotherapy. These are usually inserted in a central vein and tunneled under the skin for easy access at all stages of the patient treatment. With chemotherapy and immunotherapy, with time, the superficial veins of the patient will disappear. And I see a large portions of the patient in Bahrain receiving chemotherapy via peripheral lines, which give rise to lots of complications, especially when the treatment oozes or extravasate into the soft tissues. The other role of IR is in some treatment locally, treatment of focal liver lesions, such as providing radiofrequency ablation or laser ablation of focal liver lesions, especially if they are of a certain size. This is usually done with ultrasound or CT guidance, and a certain needle is inserted which provide an access for the radiofrequency or microwave ablation to treat the tumors. Usually this is reserved for tumors of less than 3 centimeters, usually more than multiple lesions, like up to 3 or 5 can be treated in a single session. Usually these cases are treated with local anesthesia and very light sedation. There is usually no need for general anesthesia. The other treatment option is TACE, where you have drug-eluting beads which are injected directly into the portions of the hepatic artery supplying the tumor. These usually give rise to focal treatment of multifocal disease and will improve the survival and symptoms of the patient, but it's usually not curative. It's a palliative therapy. And you have these beads, and the idea here is to do the treatment in a super selective fashion, where you bark the catheter in the main hepatic artery, and then use a microcatheter, which is a smaller caliber, and guide it directly to where the tumor is. The beads are very fine. They are micromillimeters, and they are covered with drug-eluted drugs. And they mean to block the splash of the tumor. When you do an injection of an angiogram into a tumor, you'll get the tumor creating new vascularization, new channels of splash within the tumor itself. Controlling this with and barking these drug-eluting particles into the tumor will enhance the availability of the drug directly into the tumor itself, while ensuring that there is no distant migration of these beads. Of course, before you do any procedure like that, you have to ensure that there is no shunting into the pulmonary circulation and no adjacent. And this is the most important part of this procedure, is super selective. What does that mean? Is that you bark a larger catheter, usually 5 to 6 French, and through that, through a coaxial fashion, you target the and as distal as possible into the tumor portion of the liver. Of course, not all of these branches can be treated in one session. One have to select them individually and directly give the treatment into each one of these. Then you have some of the tumors that where metastasis into the liver can be irresectable, because whatever is left of the liver is very small and cannot function or sustain the patient. And for that, you can do a portal vein embolization, where you target each branch of the portal vein into each loop and embolize it in order to deprive it of the blood retain or blood flow and enable the normal liver to hypertrophy. And with this hypertrophy, you are offering the patient an option of surgical resection of the diseased liver. This hypertrophy, usually it happens within a few weeks to a month, that will encourage the remainder normal liver segment to hypertrophy and function for the patient. I think Dr. Venkata spoke about rectal tumor stenting. And with interventional radiology, we use hydrophilic wires, which are fluid or liquid loving, and they are very slippery, with hydrophilic wires. And that enables us to negotiate very tight stenosis or almost complete occlusions within the colon in any part. Usually the distal colon, though, is what is passed. And through that, with the use of air and contrast, you can pass it successfully through the very tight or near occlusion, and then insert a stent through that to open up the blocked and facilitate more early anastomosis, easier surgery, decompress the proximal colon. There is a caveat to this. Then caveat is perforation. And how do you avoid that is you pre-dilate with a smaller balloon to facilitate the passage of this contraption with the large covered stent. You have to appreciate some stents, like the one in the middle there, number B, has a nice shoulder on the edge to transfix it into place to avoid migration. So again, you pass the wires and the catheter through the very tight or near occlusion, followed by pre-dilatation and stenting. Stenting usually relieves any obstruction in the proximal colon. The other thing is bleedings and abscesses. With interventional radiology, with the use of imaging, you can select the safest, shortest route into any collection, any bleeding point or pseudoaneurysm, and you can drain it or aspirate it or inject glue or thrombotic agent to stop the bleeding. This is a case that highlights the role of interventional radiology in the treatment of colon cancer. The case with, as you can see on the CT, hypo-attenuating lesion in the right lobe, which was seen clearly on the ultrasound, and one can find the nicest, shortest route to biopsy this lesion, get enough cores of the lesion and a good size to get an accurate diagnosis. On occasions, I had a few cases that have dual pathologies, and one would wonder which one is the cause. And the analysis of this specimen will dictate the type of regimen of chemo or immuno that the patient would receive. This can be done with any modality, but the widest use is ultrasound, followed by CT. This is another case with of microwaves of colorectal liver metastasis. Usually this is dictated to only a certain number, usually below 5, less than 3 centimeter in diameter. And this similar to the biopsy sequence, you put a needle at the heart and middle of the lesion and use a microwave of certain power to kill it with heat. And usually you allow for a margin. And usually this gives good results of survival for these lesions. Within 12 months, usually they shrink. This is another common case that can occur. This is a colorectal carcinoma with obstruction. We could appreciate in the first image multiple air fluid levels. The lumen is completely obliterated on the SAG view. This can be crossed with a hydrophilic wire and catheter and exchange and pre-dilated and stented with a covered stent, as you can appreciate. And the stent is in the heart of the area of stenosis secondary to the tumor. You could appreciate there's some fluid going through the stent, and the compression in the third picture. The amount of air in the colon have significantly decreased. The fourth case can occur with multiple scenarios, including colon. When you have an active bleeding tumor, you could super select the vessel that is causing the bleeding and stop the bleeding. How do you do that? With a sclerosing agent, coils, all of them will stop the bleeding. The bleeding vessel will be eccentric, not following the normal pattern. Usually the vessels, as you go more distal, become smaller and smaller and start branching. But suddenly you have an irregular vessel, irregular area of contrast enhancement, a small blush or a small pocket of contrast that is stagnate there. This is a bleeding source. And once you block it, all this hole in the artery will be blocked and the bleeding will stop. And the degree of hemoglobin loss and anemia will improve. This helps the surgeon to plan his case. As you can appreciate, doing an emergency colon surgery carries a far significant more complication rate and morbidity compared to a planned surgery. Also, radiology plays a major role in the following in the term of cross-sectional imaging and PET scan and nuclear medicine. So the main idea that I have to highlight, in BSH we have a complete team of all the ingredients of oncology service. We have the gastroenterologist doing the endoscopies, the pathologist reading the biopsies, we have the oncology, we have IR, and we have a great team of surgeons. All of this helps in the multidisciplinary approach to patient care. In general, IR is patient-centered, benefit the patient with multiple parameters, including less pain, fewer complications, shorter stay in the hospital, rapid return to compared to systemic therapy. And it is usually done in a day case procedure. Biopsies usually are, in the clinic itself, in and out. There is no need for admission usually. And if there is admission, usually it's done in the morning and discharged by maybe after 3 or 4 hours. This is an important part, is when to refer to an IR service. The earlier the better. Usually if you suspect or confirmed colorectal tumor with metastasis, a certain number, less than 3 centimeters for microwave. For dominant liver disease with palliative, you can refer them early for TACE, for obstruction as early as possible, so that's facilitate the future surgery and future success of the treatment plan. I would encourage all of our patients to have boards before they undergo chemotherapy. I think this is what I'm facing on a daily basis in Bahrain. The education about boards are very poor. Usually the boards will insert it in the same day. The wounds will heal very rapidly. Within 2 weeks, I will remove the sutures. Another 2 days, the whole wounds will heal and the patient will live their life. And the board could stay for 2-3 years until they finish treatment. And it is far superior than giving the chemotherapy via peripheral access. There are a lot of images in the literature and the media of extravasation of chemotherapy agent via cannula. And after 2 or 3 cycles of chemotherapy, you can imagine there are no veins to capture. Not even with ultrasound you can get a vein. And any other complications, the interventional radiology role is, it's an in-between between surgery and imaging alone. And we are here to help all the other services to come to a diagnosis quickly. I am in direct communication with the oncology on a daily basis, as well as the surgery because of that. And this is one of the advantages of the services provided at BSH and multiple other organizations in Bahrain. I think I went through that, and if you want us, this is our contacts. Thank you very much for your time.
Thank you, Doctor, for that enlightening session. Now, moving on to our next session, which highlights the critical role of radiation therapy as part of the multimodal treatment in colorectal cancer. The speaker is a radiation oncologist with over 13 years of experience, currently serving as consultant at the Bahrain Oncology Center. She completed her residency at the King Hussein Cancer Center in Jordan, where she was the chief resident, and pursued advanced training at the Moffitt Cancer Center and Thomas Jefferson University Hospital in the US. She was honored in Bahrain with the Prince Salman bin Hamad Medal for Medical Merit. Please help me welcome our distinguished speaker, Dr. Adhub Al-Hamadi.
Assalamu alaikum. Good evening. Thank you for the generous introduction. I would like to thank the organizing committee, the chairperson, secretary for their kind invitation. It's a glad to be here with you in this distinguished event. So today I'll be talking about the role of radiotherapy as a multimodal management in the treatment of rectal carcinoma. As we all know that there has been a lot of advancement in the treatment of rectal cancer in the recent years, and these changes in the multimodal management of rectal cancer has been also implemented in the different guidelines. So I'll try to move on fast for the sake of the time. So just please bear with me. So in the last decade, radiotherapy played a role as an adjunctive treatment to surgery post-operatively to reduce local recurrence. Then with a competing clinical evidence, neoadjuvant chemoradiotherapy came into the picture for a better local control and also organ preservation in the 1990s. So when you look into the guidelines, there are different modalities, new modalities, let's say, that has been implemented for the treatment of rectal carcinoma, and a huge shift in the paradigm of a treatment also is there now. So moving from total neoadjuvant therapy, which means delivering all the chemotherapy and radiotherapy preoperatively, to improve pathological complete response and also disease control. And for those patients with complete pathological response or even near complete response, we move into a new modality, which is the watch and wait approach, or the non-operative management, to avoid any surgical morbidity in these patients. Furthermore, with the molecular profiling into the picture, nowadays even our tumor boards, we emphasize to know the MMR status or MSI status of these patients, as it will shift the treatment into immunotherapy. Although these patients represent a small cohort of all rectal cancer patients, around 10%, but they do really benefit more from immunotherapy with radiotherapy. Around 80% of these patients do well with immunotherapy. Furthermore, there has been an emerging techniques in radiotherapy, such as stereotactic body radiotherapy. I won't go deep into the technicality of this procedure or technique, but we do deliver a high ablative dose locally to the tumor, and we use it in cases when we have like recurrent cases not amenable for resection again after radical treatment of these patients. In our center, we've treated a couple of cases with SBRT and such situations with good results, and we are lucky enough in Bahrain Oncology Center, to have the expertise to implement stereotactic. So as I said, there has been a paradigm shift in the treatment of rectal carcinoma with the molecular profiling coming into the picture. It's important to know the MMR status, MSI, for these patients. Also, RET fusion has been studied in a couple of clinical trials for targeted therapies in these patients. So when you look into the guidelines, the ASTRO, European, and also the NCCN guidelines, we usually stratify the patients into low-risk rectal cancer or high-risk rectal cancer, because it will allow us to manage these patients accordingly. So usually for high-risk rectal carcinoma locally advanced, we usually recommend TNT approach with organ preservation, whereas when having more low-risk patients with locally advanced rectal cancer, now according to the results of the prospect trial, we can even de-escalate the treatment by omitting radiotherapy, especially for patients looking for avoiding the late sequelae of radiotherapy. For our colleagues in radiology, we always emphasize to have a good reporting of the reports. For us as oncologists, we always follow some parameters that we look for in order to plan the management of these patients, like the tumor distance from the anal verge, the relation to peritoneal refraction, if it's above or below, as the management will differ. Furthermore, extramural vascular invasion is all important for us, and any positivity of mesorectal fascia. As radiation oncologists, we always face this question and TNT approach, whether to use the short course radiotherapy or the long course chemoradiotherapy in these patients. Honestly, the short course radiotherapy has fallen out of favor in the US practice, and we usually don't recommend the short course based on the results of the Rapido trial. I recommend short course mainly for elderly, frail patients who cannot tolerate 25 fractions of long course chemoradiotherapy, or whenever there is a metastatic disease and we want to control locally and minimizing the delay of patients from chemotherapy. But usually we go with the long course chemoradiotherapy, especially when we have high risk features in these patients. So one of the trials that compared the short course to the long course chemoradiotherapy is the STELLAR trial, which compared TNT with short course radiotherapy versus the conventional long course neoadjuvant chemoradiotherapy. It included around 599 patients with a T3, T4N disease. Regarding the results, there was no much difference in the oncological outcomes, the 3 years disease-free survival or metastasis-free survival and local regional recurrence. However, when you look into the 3 years overall survival, it favored the short arm TNT approach with short course radiotherapy. But again, a word of caution that it's hard to explain the improvement in overall survival in these patients without an actual improvement or let's say in metastasis-free survival or even local regional recurrence. Another trial is the Rapido trial, which compared also TNT approach with the short course radiotherapy versus the standard long course chemoradiotherapy. It included around 912 patients with more high-risk features of locally advanced rectal cancer. The 3 years result of disease-related treatment failure was more in the standard arm compared to the short course TNT. However, on 5-year follow-up, there was an increased local regional recurrence when using TNT with short course radiotherapy. That's why, based on these results, when you look into the NCCN guidelines, they added a footnote cautioning the use of short course radiotherapy and locally advanced high-risk features, as it might increase local regional failures based on the Rapido trial of 5 years outcomes. So we usually recommend total neoadjuvant treatment for locally advanced patients based on the Rapido Abroad J23 trial, which improved disease-free survival, pathological complete response, local control, and organ preservation. So we now know that for deficient MMR, that we usually proceed with immunotherapy for better outcomes in these patients. What about if we have proficient MMR, locally advanced rectal cancer? So we usually divide these patients into either low risk or high risk. So it will act as a framework to follow in our daily practice for these patients. So if we have locally advanced with low risk features, According to the ESMO and ASTOR, it's an upper rectal, T3AB with no nodal involvement, no extramural vascular invasion, and no positive fascia. So these patients, if we are not intending organ preservation, we go with upfront surgery, and then we can de-escalate the treatment in regards to chemotherapy based on the histopathology. However, if we have all the low-risk features but lymph node positivity, then we recommend starting with chemotherapy based on the Prospect trial. We start with 6 cycles of Folfix, and then we do a response assessment. If the response less than 20%, then we recommend chemoradiotherapy. If it's more than 20%, we proceed with surgery. If organ preservation is intended, then we just go with the long-course chemoradiotherapy followed by chemo, the TNT, usual TNT approach. So this is the Prospect trial, which included 1,128 patients with locally advanced rectal cancer, low-risk features. For node positivity, they included only less than 4 lymph nodes, not more than 1 centimeter, and the distance should be not less than 5 centimeter. So there was no difference in oncological outcomes when using chemotherapy, then response assessment, comparing the usual pathway of chemoradiotherapy. So we start with induction chemo, 12 to 16 weeks of Folfix, followed by restaging for response assessment. Whenever it's more than 20%, we can proceed with surgery. If it's less than 20% regression, then we add the chemoradiotherapy. So this allows us to omit radiotherapy in some cases and de-escalating the treatment as a new paradigm of management for these patients. So for locally advanced rectal cancer, but with high-risk features, meaning high risk for local recurrence like distal tumors, lateral lymph nodes, positive MRF or T4 disease, or high risk for distant failure like having N2 disease or extramural vascular invasion. So for these patients, the standard of care is TNT with long-course chemoradiotherapy followed by consolidative chemotherapy, then response assessment according to the findings of the OPERA trial, which showed better BCR, pathological complete response, in these patients when using chemoradiotherapy followed by chemotherapy. However, in some cases, when there is more high-risk features towards distant failure, sometimes we recommend starting induction chemo, then followed by chemoradiotherapy in these patients, or especially if we are not intending organ preservation. I've already talked about the short course radiotherapy. So for those patients who reach pathological complete response or near complete response, we move them into a protocol called watch and wait approach or non-operative management. So according to the national or international watch and wait database, it has been shown that the most critical time for local recurrence is the first 2 to 3 years. So it's always recommended that we do a close follow-up for these patients the first 2 years to detect any local recurrence. So we have the OPERA protocol of watch and wait of doing regular MRI imaging every 6 months in the first 2 years, digital rectal examination and endoscopic examination every 3 to 4 months, which is also implemented in the NCCN guidelines. Some physicians prefer to follow the MD Anderson protocol, which is more of doing MRI images every 4 months rather than 6 months. You can really tailor your follow-up according to your findings and the cohort of patients. However, it's very important to selectively choose the patients for watch and wait approach, and we need these patients to be very adherent for the close follow-up, otherwise we can shift them to surgery. So in NCCN guidelines, they have a complete paradigm of defining when we can consider these patients as complete responders based on the MRI imaging, digital rectal examination, and endoscopic findings, or near complete response. This is a homework that I will keep for the attendees in their free time, just for the sake of the time. When we can do the assessment or for the complete response, usually if we started with chemo followed by chemoradiotherapy, we wait at least 8 weeks to allow radiotherapy for its effect. If we started with chemoradiotherapy followed by chemotherapy, then not less than 1 month. If it's a near complete response and we need to follow more the patients, we wait for more 8 weeks for assessment. So the take-home message is that for locally advanced high-risk features, we always recommend the total neoadjuvant treatment, starting with chemoradio followed by chemotherapy. These are all from the NCCN guidelines, which implemented also de-escalating the treatment by omitting radiotherapy according to the prospector trial. Also implementing the use of immunotherapy with the shift on molecular profiling with deficient MMR patients. This slide represents the most important trials which shifted the paradigm of a treatment for rectal carcinoma that you can go through also. So our current challenges is to have a reliable biomarkers to better stratify patients for radiation intensity and to have a standardized surveillance for patients between the centers in Bahrain for the non-operative follow-up or watch and wait approach. Our future directions is to have like trials evaluating novel immunotherapy radiation interactions or combination in these patients. So there has been a lot of changes in the last years, refinement of the guidelines, especially in the last 3 years, also implemented in the ASTRO, ISTRO, and NCCN with more personalized medicine approach in these patients with the molecular profiling, as presented also by Dr. Mariam Fida. It's important when treating these patients to treat them as in a multidisciplinary approach with different specialties are there, and to selectively choose patients for the non-operative management. Thank you for your attention.
Thank you, Dr. Adhoub, for that valuable perspective on radiation therapy. Now, moving on to our last session, which offers a reflective perspective how oncology experience can be translated into practical strategies that improve colorectal cancer care. The speaker is a consultant medical oncologist at the Bahrain Oncology Center. He completed his medical oncology specialization at the Istanbul University Institute of Oncology and has published extensively on gastrointestinal, colorectal, breast, and lung cancer. It is my great honor to welcome our distinguished speaker for this concluding session, Dr. Ferhat Ferratulo.
Dear colleagues, dear committee members, I would like to thank you for having me here today. We are out of our time already, so I will try to highlight some crucial points and most recent developments in the metastatic colorectal cancer. So, short story, we treat colorectal cancer first in the same way. We treat all the colorectal cancers with chemotherapy only, without any biological distinction. And around 2000s, we recognized right-sided and left-sided colon cancers were biologically distinct. Their impact on they are not only prognostic, they are also predictive, influencing drug response. And after 2000s, molecular biology allowed us to identify some unique mutations, and most prominent ones are EGFR and RAS mutations. Their impact on overall survival around 6 months. Although we haven't seen a dramatic change in the last recent decades, for small subset of patients, we have now some transformative survival benefits. For example, in MSI high tumors, immunotherapies have allowed us to identify immunotherapies with the help of immunotherapy. Now we completely step away from chemotherapy, and immunotherapies providing us a very long-term survival benefits for KRAS G12C mutations. We have drugs that blocks auto-signaling in the tumor cells, and this opening the door for future developments in that area. Similarly, in BRAF and HER2 mutations, promising results have emerged, and opening the door for future developments also in this area. These trials have already been mentioned, so I will fastly skip these slides. NCCN guidelines now divide the patients in two, as MSI high or MSI low. So before treating the patients, we should definitely define the patients first according to patient's MSI status. ESMO guidelines also have adopted the same approach. It divides the patients in three as according to its mutation status and microsatellite status. BRAF V600E is another clinically challenging tumors because they have a poor response to chemotherapy. BRAF V600E drives an oncology pathway in MEP kinase, and unlike melanoma, BRAF inhibitors are ineffective in colorectal cancer, so that requires targeting both BRAF and EGFR pathway. And there are two striking trials in that area, and both of them combine this EGFR inhibitor and BRAF inhibitor. And the first line setting came with the Breakwater trial. This trial combines chemotherapy with this combination approach, and it achieved very substantial survival benefit. And guidelines have adopted their clinical approach according to these results. For rare KRAS G12C population, actually KRAS mutation occurs 40% of the patients, but KRAS G12C constitute only 3-4% of metastatic colorectal patients, and we have two drugs that inhibits the protein in its inactive state. And the monotherapy again for this subset of patients is ineffective due to the resistance mechanism, which requires again combination strategies. There are two different trials evaluating these strategies, and both of them were conducted in previously treated cancer patients, and with adagrasib cetuximab, they achieved almost 16 months overall survival benefit, even though these patients received at least three prior lines of therapies. So this treatment approach actually seems encouraging. KRAS G12C mutations, as a clinician, it should be known that it generally in the patients with history of smoking and right-sided colorectal cancers. But we need to still detect this mutation if we want to use this approach. So since we find this approach, this can be expanded to other KRAS mutations maybe in the future. So this is an important development in that area. HER2 is another subset of patients. It occurs only 35% of colorectal cancer. It's almost entirely occurs in the RAS-wild tumors, and generally these tumors are resistant to EGFR therapy, requiring alternative strategies. Some early studies evaluating trastuzumab-based combination showed some signaling about that. HER2 positivity is quite different from breast and gastric cancer. It requires complete circumferential stain, and it should be at least 50% of the cells. So it shows that the heterogeneous nature of the disease. Trastuzumab-based treatments achieved almost 30% of overall response rate, and with the trastuzumab deruxtecan we obtained more than 25% of overall response rate. But these trials were not enough to approved by FDA. So the tucatinib trastuzumab trial was the first dedicated trial for metastatic colorectal cancer patients. Overall response rates in that trial 38%, and median overall survival is more than 2 years. So these results really encouraging. Tucatinib is a small molecule that inhibits the EGFR receptor in the cell. On the other hand, trastuzumab binds the EGFR receptor outer surface, and by combining them, the receptor degradation can be increased, and with this approach, we see that in that area, if we taken together all of the treatments from now on, there is only 15 to 20% of patients that can be targeted with these treatments. So majority of the patients still needs chemotherapy in that area. Chemotherapy remains the backbone of our treatment approach. The problem in here, again, the resistance mechanism, and also tumor nature is very heterogeneous, and we are seeing very secondary resistance, unlike non-small cell lung cancer, melanoma. So we should investigate more actionable drivers in that area. In the next decade, still we can expect some combinational approach with target treatment and immunotherapies or antigen drug conjugates. We can use some tumor agnostic approach, some liquid biopsy to guide our treatments, and also there are new targets in the way to expand our treatments. So, but for now, we still not there. We should still use chemotherapy for this treatment. I would like to thank you for the organization committee.
Thank you, Dr. Farhad, for that insightful concluding session. Now, ladies and gentlemen, due to time constraints, we will not be able to continue with our panel discussion as originally planned. We would, however, like to sincerely thank our esteemed panelists for their willingness to contribute and share their expertise. Your presence is deeply valued, and we look forward to future opportunities for discussion. Now, to officially close today's program and deliver the vote of thanks, may I now invite our Chief Executive Officer, Mr. Majid Ardati. And following the vote of thanks, we kindly request all speakers and guests to join us at the front for a group photo.
Thank you very much, everybody, for spending the night with us, talking about a very important disease that is quite prevalent, and we're seeing a lot of cases in our patient population in our country. I think from screening to treatment to genetic aspects to new technologies with interventional radiology, we tried to be very ambitious in what we covered tonight on this subject. And I think we are sometimes too ambitious when we hold these events, and we try to do so much because there's so much to share. I really would like to thank everybody for spending this night with us, giving us your attention and your time, and especially sharing your experience and your expertise. I think in this room we have a sum of knowledge that is uncomparable, and we really appreciate everybody giving their time and contributing and sharing that with the rest of us. I'd like to thank, obviously, our chairperson of the event, Dr. Najah Zayani, and the rest of the speakers who really put in a lot of effort into what they did tonight. I'd like to also thank our sponsors who, also made this event possible at such a nice venue where we could talk about all these important events. Obviously, we have Spemaco, IPCA, Julfar, Asinofarm, and NPI, who were very kind to sponsor this event tonight. I, again, would like to thank everybody for having the patience to listen to all of these interesting subjects and topics. Please join me on stage for a group photo, and then we can all go have some dinner as well. Thank you so much, everybody. We'll line it up so that we have enough space.
to meet you.
I think we have a few patients in front row.
No, no, the patient. Husseini, yes, yes. She's not very good. I put the patients right. Professional.
Thank you very much, everybody. يعطيكم العافية. عشان ما يغطي عليه شيء. Thank you very much.
مشكورين. Thank you.
شكرا شكرا.
Okay. يلا organizing team.
شكرا دكتور، شرفت بيك.
أهلا.
شكرا.
Organizing team. شكرا.
يعطيكم العافية. Thank you so much.
Organizing team.
يلا يلا.
Very nice, fantastic. This is Dr. Naresh. He joined Aster as a surgeon. This is Dr. Qasim. He's the boss. She's the boss's boss. She's the boss's boss. She's the boss's boss. Thank you. Oh, he's the butt.
Amira will come next to you. Who?
Dr.
No, I will stand beside you.